X-ray? Ritika?
Yes, sir. हाँ sir, कर रही हूँ.
Full screen. Okay.
आ गया ना?
Hmm.
Yes, sir. We'll start or we'll wait for some time.
35. Half of the people have joined. Another 2-3 minutes.
Yes, sir.
Let's take a break.
It's visible?
Yes.
Can we start now?
Yes,
Yes, ma'am.
Yeah. Let's start. So again, 15 minutes for that. Read and answer.
A 67-year-old male is admitted with transient ischemic attack, routine chest X-ray. Study and report the chest X-ray. What procedure has he had? This man has had TIA, routine chest X-ray was done. This is seems like a AP view. The trachea is pulled towards left side. The left side is lung field is not visible. Probably there is a bronchus cutoff. So due to main bronchus being obstructed by secretions, there is lung collapse.
Okay.
And
Anything specific about this? Main bronchus cut off and pulled towards the left side.
mediastinum is getting pulled towards one side in this X-ray.
Pardon?
Mediastinum is getting pulled towards
Yeah.
left side.
Anything specific you can say about this?
The right side looks hyperinflated.
Yeah.
Vascular markings are very prominent, like patient has underwent volume reduction surgery maybe.
Yes.
And then the lung is not there on the left side, pneumonectomy.
Yes, pneumonectomy, correct.
This patient presented with abdominal pain, nausea and vomiting and constipation. Comment on chest X-ray and possible diagnosis. This is a AP view, erect. After the horizontal fissure of the right side, there are few bronchograms available. Air bronchograms are visible. It looks like a consolidation on the right.
So where it is
right.
exactly? This one, this one,
Ma'am, yes, this one.
this one.
Ma'am, more towards periphery.
This one.
Ma'am, yes, ma'am.
Read the question again. There is a hint.
Abdominal pain, diaphragmatic tenting.
Abdominal pain, nausea and vomiting and constipation.
The bowel loops, it seems like there are bowel loops.
Because your diaphragm is this one, right?
So these are not bronchograms. The diaphragm is up. So
so if this is you're saying because he is having somewhat features of obstruction, right?
yes.
So if this is a bowel loop, usually do we see bowel loops this side?
No, ma'am.
So in what special scenario we can see bowel loops here? Can you name that?
No, no,
Okay. Okay. ठीक. So that's good. Means you identified what is the problem. I'll explain that in the answer.
A 64-year-old female morbidly obese patient, septic shock, intubated, suddenly found to get desaturated and difficult to ventilate.
Sorry.
That
My screen is visible, na?
Yes, ma'am.
Huh.
A 55-year-old man, alcoholic, presents with acute abdominal pain. On examination, he had significant generalized abdominal tenderness. A propped up chest X-ray was undertaken. Describe the chest X-ray. What is your diagnosis and subsequent management? Uh, this patient has this is AP view. There is right side the cannulation. The central line is placed. It is entering. Right. The acute abdomen is there. Alcoholic, 55-year-old male. Abdomen tenderness is there.
What all you can see in the chest X-ray?
Some reticulations are there, but they are homogeneous and on both sides. There is no rotation also, and but
Anything
the
on
diaphragm, the diaphragm of right side, there is some air below the diaphragm.
there is gas under diaphragm.
Yes, there is gas under diaphragm. Could be due to perforation.
Yeah.
My diagnosis just on that history and alcohol and tenderness is perforation peritonitis, and
Yes.
he require acute abdomen workup. Management would be in initial fluid resuscitation, adequate volume loading, and uh, treat laparotomy. Yes,
Antibiotics.
antibiotic.
Antibiotics.
Yes, BLBLI.
Yes.
This is a CT KUB. Uh, the right compared to right, the left kidney looks globular, increased in size. The pelvic calcial system, there is stranding is there around the pelvic calcial system. I'm not sure that is the emphysematous pyelonephritis.
Why not sure?
Because there is air also.
Yeah.
And
so these are
yes,
airs, na?
yes. Emphysematous pyelonephritis could be there.
Yes. So what are the organisms responsible for most commonly seen with emphysematous pyelonephritis?
Enterobacter.
Gas producing organisms?
Anaerobic.
What else?
Anaerobic lactate producing organism, non-fermenters.
Fermenters.
Sorry, fermenters.
Yeah.
I mean, Pseudomonas, Klebsiella.
E. coli,
Gram,
Klebsiella.
E. coli.
Most important. Yeah.
E. coli.
Yeah. So antibiotics?
Antibiotics more for renal tissue penetration, like tigecycline.
Alone? Tigecycline?
No, not tigecycline, but like BLBLI. If ESBL, then meropenem. Then if carbapenem resistant Enterobacter, then tigecycline. Even
Cycline, it is not very well secreted in the kidney, na? Excreted in the kidney. So we avoid tigecycline for renal pathology.
Okay.
Carbapenem has very good penetration.
Carbapenem. If carbapenem resistant, then fosfomycin.
Yeah, that you can consider. And what will be your management action? Next step management?
Source control.
Yes.
Percutaneous nephrostomy.
Either.
Source control.
Oh.
DJ stenting if
Yes.
for relieving obstruction on PUJ junction.
Yes.
Relieving the pelvic calcial system.
Or what other option? If patient is very sick and
You have to get rid of the kidney, then nephrectomy
Yeah.
will be needed.
right.
A 58-year-old male is admitted to emergency department with altered level of conscious state following a fit. Little else is known about him. Describe the CT. List the most likely cause. Name 3 trials on mechanical thrombectomy. So the hint is already, I think. This is a stroke. This is a CT of cerebrovascular sepsis showing loss of cervical gyri effacement. The gray-white differentiation is lost on the right side, and it is more in the region of MCA territory. It seems like a large MCA infarct. The bloodline shift is started to happen.
Yes.
Cisterns are blocked, so maybe ICP is very much raised. Most likely cause is MCA infarct. Trials
So
decimal
most likely causes of this MCA occlusion.
MCA occlusion thrombotic stroke, large vessel MCA occlusion from the M1, M2, M3 bifurcation. Before that, proximal to the bifurcation only. The trial.
What are the, I wanted to ask you what are the causes? If the patient is presenting with this, what you can think why this had happened? What could be the possible causes for that?
MCA infarct causes for MCA infarct.
Thrombotic one you said.
Thrombotic, embolic.
Huh?
Embolic looks less likely since it's a large MCA, so I was not saying that.
It's not impossible. Thromboembolic most common.
Thromboembolic, watershed infarcts, not
No.
septic.
Okay. 3 trials on mechanical thrombectomy.
Decimal trial, Destiny, Decimal, Hamlet. All 3 trials showed mortality benefit with mechanical thrombectomy. Sorry, for mechanical thrombectomy, Dawn and diffuse. And one more was there, MR clean trial.
Yes.
Revacast trial is also there.
Reversed. Yes. Okay. Read this.
This is a thromboelastogram. This is the diagram of thromboelastogram. The R time looks increased in this. The R time normal is supposed to be.
Just tell me the abnormalities.
Increased R time.
Time
increased.
The value is given over here, so
yes.
You can answer it.
R time is 2 to 8 so it is increased. So there is abnormality in coagulation, decrease in clotting factors that are supposed to be replaced.
Read the full text, Dr. Gurkirat.
Okay.
What about K time?
K time is 24.3. So it is very much increased.
What about
hypofibrinogenemia is also there.
Yes. What about angle?
Alpha angle is 10.9. So that is also decreased.
What about maximum amplitude?
The platelets are normal, seems to be normal because
Hmm.
maximum amplitude is within normal limit.
Yes.
The
What it will be
hypo
suggestive of?
hypofibrinolysis with decreased clotting factor like DIC. Platelets are fine.
So your platelets are fine. Means
Traumatic coagulopathy.
you have deficiency of?
Platelet of clotting factors.
Yes.
Yes, they are supposed to be replaced first, then cryo for fibrinogen.
Because there is factor deficiency.
Yes, ma'am.
Any specific disease you know which can present like this?
If patient is on factor 10 inhibitors, like if patient is on apixaban,
Hmm.
if patient is on other and on factor 10A inhibitors, that can be that can be reversed.
Hemophilia
Factor
patients also
factor
can
8
present like this.
factor 8 deficiency
Yes.
hemophilia.
Yes.
I just written there. I just read it. A 35-year-old female presented to emergency following a fit. She was complaining of tingling in the right side of her face, her left hand, and had vague headache. No hard neurological signs are present, though she has mild abdominal tenderness and is slightly jaundiced. An occasional petechial spot is noted. Her temperature is 38.2 degrees Celsius. A blood film of hemoglobin of 8.6 gram per deciliter, a platelet count of 49,000, and white cell count of 12,000. The following blood film is performed. What does the blood film shows? The blood film is showing hemolysis. There are fragmented RBCs. There are some burst cells there. Schistocytes are there. Thrombocytopenia is also there. This patient is young male. There is headache. So like there is a pentad. It is going towards pentad of thrombotic thrombocytopenic purpura.
Good.
Uh, what
So
treatment
treatment.
has been shown to improve outcome? Plasma exchange with the with the with plasma exchange with wall plasma only, 1 to 1.5 times the
And
volume.
what else?
Uh,
If suppose plasma exchange is not possible.
if Plex is not available, then uh, Plex
Alternative to flex, what is there?
plasma replacement. If like the factor, if mm, if Vobel pellet body deficiency is there, then
IVIG.
hello.
IVIG we can use, na?
Adamets 13 deficiency is there. If then FFP will help. But if there are antibodies to it, then plasma exchange will be have to be done.
Only FFP you will not give, na? You will give FFP for the plasma exchange.
Yes, ma'am.
You're doing. I'm asking what is the alternative treatment for the if plasma exchange is not possible, then what?
Uh, methylprednisolone,
Okay, steroid is one option.
immunosuppression. Uh,
Other than that,
Plasma exchange.
IVIG.
IVIG. Yes, yes, IVIG.
Okay. What happened? Yeah.
A 44-year-old woman present with marked weakness. She is unable to stand from chair and can hold her arms above her head. Routine Tests reveal biochemistry. You were asked to give an opinion. Describe the results. What is the cause of her weakness? The sodium is 146, potassium is 2.4, chloride is 108, bicarb is 35, urea of 8.1, creatinine 110, 72, 20 micromole is normal, glucose of 9.4. This could be suggestive of hypokalemic periodic paralysis after a heavy carbohydrate meal. Whereas the glucose and potassium.
But why sodium is then going on the higher side? Bicarb is 35.
The renal tubular, no.
Creatinine is normal.
Yes, that is normal.
So
Potassium
cause of weakness is right. It is hypokalemia related. But
corticocortic,
yes,
the symptoms, the constellation is suggestive of hypernatremia, hypokalemia, alkalosis. So
going towards
steroid related weakness. I'm
so
not
what we
sure
say,
about that.
what is that syndrome called?
Hyper
So this is going towards excess ACTH production.
excess ACTH
So what is
production.
that? What is this combination?
Excess ACTH production, Cushing,
Yes.
not
Cushing. Hypernatremia,
hypernatremia.
hypokalemia,
Yes,
alkalosis. Hyperglycemia is also there, in fact.
Cushing's syndrome.
Going towards that. This picture is going towards Cushing syndrome only.
Yes.
Because, and what other things can cause this kind of picture?
Iatrogenic steroid.
Like? Okay. Other than steroid, what other medication? Any medications can produce some picture similar to this?
Yes.
Any diuretic group?
Sodium, potassium, if they are inhibited, then there will be loss of lot of potassium. Sodium will still be reabsorbed. Loop diuretic.
Yes, and?
Thiazides.
Yes. Okay.
You are asked to assess 30-year-old schizophrenic women with no known medical history who has presented to emergency department with reduced level of consciousness. Clinically, she appears euvolemic. Describe the abnormalities in the following result. List the possible etiologies. The sodium is 114. She is schizophrenic, 30-year-old woman. Potassium is 2.8. With decreased level of consciousness, she appears euvolemic, but the chloride is 77, which is very low. Bicarb is 27. Urea of 2.2. Creatinine of 44 of 7 millimole is also very low, 242. The urine osmolarity is 50. The urine sodium is 15. Urine sodium, it is urine is conserving sodium. Hypo.
Read out what are the problems. Read first out that. What are the problems mentioned here in the on the basis of this biochemistry report?
30-year-old schizophrenic.
Okay. So what are the sodium?
Low osmolarity.
Yes.
And urine, I'm not sure.
But what are you finding in the urine osmolality?
That urine osmolarity is also on the lower side. In the
Yes.
urine is also
So can you
pulse. I'm not. Actually, I'm not sure because the constellation
how is the
is like
urine
not going
osmolality? How is the
in
urine
that.
osmolality?
It is also very low.
In which condition urine is so much diluted?
Uh,
Psychogenic polydipsia.
okay, psychogenic
Patient is
polydipsia.
euvolemic.
Yes,
What
yes.
you will expect is, reading schizophrenic, what you will expect about the most common cause of sodium hyponatremia? SIADH.
Yes, I was thinking like on the lines of antipsychotic drug,
Yes.
maybe that
But
cause.
what you will expect for the urine osmolality and urine sodium in SIADH, that you should remember.
It should be euvolemic and the sodium should be low, but the urine sodium osmolarity would be very high then
Yes.
in that
Exactly.
situation.
Yes.
Yeah, that is why I was not sure.
You were right. You have to be sure about it. Okay, that's it. You took time, Dr. Gurkirat. So it is 15 minutes. You took 25 minutes total. But
Yes.
you answered almost all questions. That's good. We will just see the answers now. Where is that? Oops. 1 second. I'll have to open. Yeah. My screen is visible. No. My screen is visible.
Yes, ma'am, it is visible.
Okay. Thank you. Okay. So this is rightly said. It is, you can see the bronchial stump and loss of lung volume. Small part is left. So it is pneumonectomy. Because of that, the trachea is pulled towards the left side. TIA, nothing related to TIA. It was just a routine X-ray. So chest X-ray, AP view, left ward shift, bronchial stump, small remnant of the left lung seen, and it is status post left pneumonectomy. Then this one, this is a very classical X-ray, not very common, but it's a rare X-ray to be seen. This is the bowel loops. Okay, you can see the bowel loops. In fact, these. Okay, so whenever the bowel is coming, this is what chillarity sign. Someone rightly mentioned in the chat box. If the bowel loops are present between the liver and the diaphragm, it is chillarity sign. What I yesterday also told you, Dr. Gurkirat, that even if you don't know the exact diagnosis, you are seeing, it will help you to score more than 50% of the marks. Okay, so this is chillarity sign, bowel loops coming between the liver and the diaphragm. Chillarity syndrome is when this syndrome. Okay, these are special X-rays. So section of colon between the liver and the diaphragm. You can see the hostrations also in that. So this is I think so this is pneumothorax, bilateral pneumothorax with surgical emphysema. And this patient, we giving CPR, the patient was not coming out. We were not able to achieve the ROSC. But once we put the needle decompression, bilateral ICT insertion, patient got revived. So this one, don't miss this finding. This is the diaphragm, and you can see gas under diaphragm. This can be as thin as this. So don't miss this kind of finding in chest X-ray, because this is your MBBS days K X-rays. So obviously this is right side gas under diaphragm, perforative peritonitis, and the treatment wise, resuscitation, antibiotics, and urgent surgical intervention. So this, you rightly mentioned, this CT KUB with contrast, okay? And that is showing your emphysematous left kidney with the emphysematous pyelonephritis. So what are the organisms responsible for it are E. coli, Klebsiella, most common. We have to give appropriate antibiotics and urgent surgical intervention, including degestenting or partial or total nephrectomy, depending upon the patient's condition and the appropriate treatment wise once the urologist feels so. This you rightly mentioned. You mentioned almost each and everything, every findings in the CT scan, CT brain plane, showing hypodensity in the on the right MCA region, and midline shifts, the loss of sulci gyride loss of gray white matter differentiation, and the ventricles are almost chunked, and most important causes thrombotic, embolic, atherosclerotic vessel dissection that you need to remember. And these are the three main trials which was done. That is Dawn, Diffuse 3, Mr. Clean, Extend 1A. But these trials you should know that what was the outcome. So TEG, again, I'm telling you, even if you don't know what is the diagnosis, just read the findings. R time is so much prolonged, K time is so much prolonged, angle is decreased, but maximum amplitude is towards the normal side. So this is clearly not the DIC picture, because factors deficiency are there, but platelet function or platelet numbers are okay. Platelet function is fine. So it is factor deficiency. Factor deficiency, most important, we will think of hemophilia. This, you rightly mentioned, the findings of schistocytes are there. Many schistocytes you will be able to see, and some Burr cells are also present. The picture is classically fitting into the TTP pentad, with patient presented with the neurological symptoms, fever, hemolysis. In the picture also, it is suggestive of hemolysis, and renal failure. Along with that, thrombocytopenia. So it is not a very common presentation that all five things you may not get in one patient, but yeah, you can think about it. So treatment options are supportive care, corticosteroid, immunosuppression, along with the immunosuppression, FFP for plasmapheresis and immunoglobulin. 44-year-old woman presented with marked weakness. And so took some time, but lastly, you mentioned, right? So hypernatremia, hypokalemia, along with that, metabolic alkalosis, bicarb is on the higher side, and others are okay along with hyperglycemia. So this is fitting into your Cushing's syndrome. But other cause, as you mentioned, diuretics, potassium wasting diuretics, loop diuretic can also lead to that, and thiazides also could be the possibility. So weakness is keeping with the proximal myopathy in hypokalemia. Hypokalemia is this low is due to excess ACTH productions, can also happen like bronchial tumors, but may also with exogenous steroid that you mentioned, or pituitary ACTH release. Next is this schizophrenic with hyponatremia, euvolemic, not hyper or hypovolemic, because so there is hypokalemia, hyponatremia. This is true hyponatremia because your osmolality, it is hypoosmolar. And along with that, you will see kidney is almost maximally diluting the urine. So this is going towards your psychogenic polydipsia. In that condition, patient will be euvolemic, but kidney will. So hypoosmolar, hyponatremia, hypochloremia, normal osmolar gap. You should know normal osmolar gap and how to calculate osmolar gap also. Urine osmolality on the lower side and urinary low urinary sodium. So again, even if you are not able to interpret, just mention what are the abnormalities you are seeing. So it is hypoosmolar hyponatremia with normal renal function and maximally dilute urine. So it is mostly psychogenic polydipsia. Other, as we discussed already, SIADH, but urine will not be diluted and urinary sodium less than 20 is unlikely. Hypothyroidism, drugs, carbamazepine, chlorpropamide, and glucocorticoid deficiency. But in glucocorticoid deficiency, what you will expect? Addison's hyperkalemia, not hypokalemia. So here the best hint was your hypoosmolar urine. Okay. So now who is coming for the next instrument and drugs? Good, Dr. Gurkirat. You did well. Who is going? Who is
Any
going
volunteers?
to volunteer next? I'm trying to see the participant's name. Yeah. Anyone from who is there? Dr. Annapurani.
Dr. Arnab Banerjee, he told yesterday that he will volunteer today.
Dr. Arnab, is he there?
Yes, ma'am.
Shall we start with the drugs and instruments?
Okay, ma'am.
My screen is visible?
Yes, ma'am.
Okay, let's start. I'll start the timer. Try to complete within 15 minutes. Identify the machine, indications, and name 3 trials related to it.
Ma'am, ECMO machine, most probably this is a
That's okay.
VA ECMO. Yeah, most probably ECMO and indication, ma'am, if it is VV ECMO and VA ECMO, the indications will be different. VV ECMO mostly for lung pathology, COPD, refractory COPD not adequately maintained on ventilator, or refractory asthma, or VA ECMO if for indications like cardiac indications, pulmonary embolism, myocarditis or cardiomyopathy, or heart failure.
Okay,
And
so
trials related, ma'am, trials will be Caesar trial, Eulia trial, and
Caesar and Eolia are for VV or VA?
ma'am, for VV.
And for VA, you know any trial?
Ma'am, I cannot recall at this moment.
Okay. Oops, sorry. This is the answer sheet. Wait. I'm so sorry. What is this?
Ma'am, this is a tracheostomy tracheostomy tube,
Hmm.
8 of size 8 cuffed tracheostomy tube, silicon cuffed tracheostomy tube.
Hmm. Along with that, anything else?
Yes, ma'am, subglottic suction with
Yeah.
subglottic suction.
So what are the indications of percutaneous tracheostomy?
Ma'am, neurological patients in which I am expecting prolonged ventilation, weaning failure patients,
Hmm.
and uh, difficult weaning failure patients, and trauma patients um, requiring prolonged ventilation,
Hmm.
and mm, and uh, patient requiring patient with high secretion requiring tracheostomy, tracheal suction, toileting, and mm,
Okay. You answered, but you can answer it in a better form, in a more organized way. Okay. Just prepare like that. What is this?
this is a sense taken Blackmore tube.
Very good.
Yes, ma'am. Next question.
So what is the use of Sangstein Blackmore tube?
Upper GI bleed in controlling upper GI bleed by tamponade effect,
So we use this in all
compressing
patients.
the esophageal-gastric junction, compressing a variceal bleed, ma'am.
So we are using in all the patients. Are we using
Rarely
it?
used nowadays,
Why? So
ma'am, due to complications, ma'am.
so
Like,
when you will ask for this tube in your ICU?
ma'am, when um, urgent endoscopy situation is not available, or if
Hmm.
gastroenterologist or in-house gastroenterologist or
Hmm.
endoscopy suite facility is not available,
Hmm.
and massive bleed, not responding to medical management, and
So it was discussed
risk
yesterday,
of,
the case also.
yes, ma'am.
So you're right.
I
It's
I
emergency.
couldn't attend, ma'am, properly yesterday's
Okay,
yes, due
no
to
issue.
bleed.
So we'll discuss the answer, but almost you answered the question. Only other thing is ki if it is not getting controlled with the upper GI endoscopy,
Yes, ma'am.
at times this can happen. What is this? Just name
Ma'am,
the
this is a video laryngoscope, ma'am.
and uh, is it your part of difficult intubation cart now?
Yes, ma'am. It is a part of difficult intubation card.
So name the medication group, which organism it will not cover.
Ma'am,
Yeah.
this is while showing cholestyramine sodium
Hmm.
and group, ma'am, cholesterol belongs to uh, polymyxin group.
The mechanism of action, matlab what, how,
Ma'am,
uh,
it is
huh,
ma'am, mechanism of action bactericidal uh, by
how,
um,
where it acts.
cell membrane,
Yes.
cell membrane.
Which organism it does not cover?
Ma'am, Bartholdi,
Okay. What else?
Bartholdi, and mm,
Hmm? If you are not finding anything, at least say gram positive, it will not cover.
yes, ma'am, gram positive and
Yeah.
Bartholdi.
No, but other gram negative, which it will not cover. No?
Mm.
Okay. So what is this fluid? Under which category it falls?
Ma'am, it is a crystalloid. It belongs to crystalloid. It is a It is basically cabilite, that is
Huh?
plasmalite A.
Which fluid category it comes in? Wide category?
Crystalloid.
Balanced salt solution.
Balanced salt solution. Yes, ma'am. Sorry. Balanced salt
So can
solution.
you name trials on balanced salt solution versus normal saline? The recent one very recent trials on that. 2018 onwards. 3-4 trials has been done.
Salt, basic
Huh?
and
Huh?
basic trials, basics and plus,
Huh?
and salt,
Salt. Aage?
salted,
Salt ED,
basic
yes.
and salted,
And
basic and plus.
so salt ED came with one more trial. Smart and salt ED came together.
Smart, yes, ma'am. Yes, ma'am.
Yes.
Smart, yes.
For
Yes, ma'am.
fluid, you should know these trials in and out with the outcome,
Yes.
okay? And
Yes,
including the population also on which it was studied. What is this? What is this? Which group it falls? Name it, na? Name the antibiotic.
Yes, ma'am. It is dalbavancin injection.
Which group of antibiotic it
Dalbavancin.
is? Which group of antibiotic vancomycin belongs to?
Gram for gram-positive organisms.
But which group?
And yes, ma'am.
Based on their chains, na? Based on their
Yes, ma'am.
biochemistry. Nahin? So which organism it will cover?
Glycopeptide.
Yes, lipoglycopeptides. Which organisms it will cover?
Non-gram-positive organisms.
Be more
MRS,
specific.
MRSA,
Huh?
MRSA,
And
MRSA, MS. This,
MSSA तो ठीक है, but this will be, you can say, inferior for MSSA. Inferior
yes, ma'am.
to
Yes,
your
ma'am. Yes, ma'am.
cefazolin and all. So
Mhm.
VRE also it will cover, na? That is, these are the advantages of the newer.
Sorry, ma'am. I couldn't hear you, ma'am. What you said?
VRE also it will cover.
VRE, yes, ma'am. Yes, ma'am. Yes, ma'am. Yes,
These are the
yes,
advantages
yes.
of the newer antibiotics coming for the positive cover, na? Because this will
Yes,
cover
ma'am.
MRSA and VRE also. And now in India, we have increasing resistance of the vancomycin also. Can you
Yes,
name, can you tell me what is the most important advantage of this antibiotic apart from this MRSA and VRE cover as per the dosing is concerned? You have any idea?
no, I'm not sure. Maybe once a dose, once daily. I'm not sure, ma'am.
Okay, once a week. Okay, what is this?
It is magnesium sulfate, ma'am. Vial of magnesium sulfate.
So tell me one important life-saving indication of magnesium sulfate.
Ma'am, antiarrhythmics in torsades de pointes. This can
Perfect.
be,
Yes, other than that,
ma'am, as nebulization in severe bronchospasm.
is it known to be
And
when benefits are there?
can be used.
Not much. So other than that, when you are very commonly using this in the ICU.
For
What?
atrial fibrillation
Okay.
and hypokalemia,
Yes. And
refractory hypokalemia.
yes.
And ma'am, in in eclampsia patients, ma'am, for controlling
Eclampsia
seizures.
patients. Yes,
Yes,
that
ma'am.
is
I've
also very
said that
important.
before.
Yes. And also in refeeding syndrome also you can see the
Yes, ma'am.
hypomagnesemia chances are there. So that there also it is important to replace. What is this?
Ma'am, tablet digoxin.
Which category of medication it falls to?
Mm, this is it falls in the anti-arrhythmic classification now. Um, means groups, I have to say.
Anti-arrhythmic. No,
Digital is group
uh,
glycosides,
yes, cardiac glycosides.
cardiac glycosides.
Yes. So, can you tell me what is digitalis effect, digoxin effect?
Yes, ma'am. With ma'am, when the patient is digitalized, means ma'am, patient will present with bradycardia.
Digoxin effect and digoxin toxicity are same or different? Hmm? Uh, are you there?
Yes, ma'am, I'm there. I'm
Ah.
thinking actually.
Ah.
You can recall,
Digoxin
ma'am.
toxicity and digoxin effect, both are same or different?
Ma'am, both are different.
Okay. So what is digoxin effect? Where it is seen?
I have to read it, ma'am.
Okay. We'll go to the next question.
Yes, ma'am.
What is this?
Ma'am, this is prothrombin complex
Hmm.
concentrate.
What is the constituents?
Ma'am,
Sorry, it's
I
not very
cannot.
clearly visible, but obviously
I
you
think
can.
it is 4-factor, ma'am. I think it is 4-factor.
Which one?
Factor 2719, 2719. 4-factor prothrombin complex and protein C, protein S.
Perfect. Indication?
Ma'am, indications in DIC,
Okay.
liver failure,
Okay.
volume overload,
Hmm.
and liver failure with volume overload, in which
Mhm.
we'll try to give.
Hmm.
And ma'am, DIC and ma'am, and in
Hmm. 2, 7, 9, 10.
yes, ma'am, factor deficiency and
So, any
vitamin.
medications, antidote?
Yes, ma'am, warfarin,
So when,
warfarin antidote.
yes, so you can use it for the warfarin reversal also if any patient is coming for any emergency surgery or with bleeding on warfarin.
Yes, ma'am.
What is this?
And this is 20% human albumin.
What are the indications of albumin infusion?
Ma'am, in ICU, the indications is large volume paracentesis. And ma'am, SBP. Replacement fluid in plasma exchange.
Yes.
Resuscitation we can use sometimes, but
Sometimes when we prefer albumin, obviously it's not preferable, but when
volume,
Hmm.
ma'am, when we have done with the crystalloids, so for volume expansion,
as a
sometimes,
rescue
ma'am.
treatment.
Yes, ma'am.
So can you name 2 trials on that?
Ma'am, Albios trial and SAFE trial.
Perfect. Very good. What is this?
Ma'am, this is Ertapenem.
Which
This
group of
belongs to
antibiotic?
carbapenem group.
Yes. And what is the benefit of using this ertapenem over meropenem?
Ma'am, once a dose, once
Perfect.
daily.
Very good. And which organism it will not cover?
Ma'am, for Klebsiella, ertapenem is not very good, but it can have resistance up to 30% for Klebsiella specifically.
Which organism
And
is resistant to ertapenem? Meropenem is a very good choice na, for gram-negative organism. But one
yes, ma'am.
very common pathogen for which ertapenem is not sensitive. It is resistant. Pseudomonas.
Yes, ma'am.
What is this?
Ma'am, this is a vial of voriconazole 400 mg.
Hmm.
Um, and ma'am, it is an antifungal, belongs to antifungal.
Which group of antifungal? Ma'am,
Azoles.
So what it covers?
Mm,
Very important where we use to cover which.
Aspergillus, ma'am.
Okay.
Aspergillus species.
And
And
which? So
salvage therapy.
my next question is which form you will prefer, IV form or oral form? And why?
Ma'am, IV form, I will prefer the oral form if patient can tolerate, because in IV form contains, ma'am, cyclodextrin, which is nephrotoxic, which can cause nephrotoxicity.
Very good. Okay, good. So 19 minutes. That's good. Very good, Dr. Arnab.
Thank you. Thank you.
We will share the answers. Almost you answered everything. Was that too easy for you?
No, ma'am. Some
No,
of
but
the questions I should have answered. I should read some of the questions I missed.
that's okay. If you will answer 100%, then you will feel that your preparation is 100%. So then you have to work always hard, no?
Yes, ma'am.
Here, no? So ECMO machine indications. So respiratory failure, you said it right, that COPD patients, bronchial asthma patients, but I was expecting that you will say ARDS, right? Because ARDS
Yes, ma'am. Actually, at that moment, I missed it.
very commonly we use in ARDS, and that too the indication is when PF ratio is going below 80 or PaCO2 is persistently increasing more than 60 with significant acidosis. Cardiogenic shock as bridge to recovery or transplant. In ILD patients, if they are coming with the hypoxia, so it is in ILD patients, I'm saying. I'm not saying it's in ILD patients, bridge to recovery. ILD patients, bridge to transplant, because obviously we are not expecting that patient is going to recover with that. Trials, Eolia trial, Caesar trial, you already mentioned. For VA ECMO, it is CS ECMO, cardiogenic shock ECMO trial. You know the difference between Eolia and Caesar, right? This you can get in the literature review also, how to read the paper. So because these are very landmark trials. So this is tracheostomy tube. You answered all the parts. Only obturator you could have asked. You could have said that. So tracheostomy tube is epiglottic suction with obturator. Indications you mentioned, but you have to be more organized, that indications in emergency tracheostomy and elective tracheostomy for ventilation, difficult weaning, and for long-term permanent tracheostomy with like in these CA larynx patients and neuro patients where the patients are not able to maintain the airway toileting. Sangstick Blackmore tube, rightly mentioned, emergency procedure to control the esophageal or gastric varices bleed if endoscopy not available or failed. Video laryngoscope, this is a part of your difficult airway cart. So you all should have hands-on practice on this video laryngoscope. So colistin, polymyxin group, it acts by cell membrane lysis, does not cover gram-positive and Proteus, Providentia, Burkholderia, also Morganella also. So you just remember this because we are using very commonly. So this is Cabilite. This falls under balanced salt solution. Trials related to that smart salt ED plus study and basic study. So again, all trials on fluids, RCTs I'm talking about, not the other trials. All RCTs on fluid, including balanced salt solution versus normal saline and crystalloid versus colloid. You should remember it. Dalbavancin, rightly said, lipoglycopeptide group, once a day dosing, that is the benefit. It covers MRSA and VRE. So magnesium sulfate, you answered everything related to that. Torsade pointis, then your eclampsia. Though we don't see many cases, but definitely this is the indication for magnesium sulfate. Refractory hypokalemia, atrial fibrillation as a membrane stabilizer, and refeeding syndrome. Digoxin tablet, yes. So this falls under cardiac glycosides, and digoxin effect is when its effect is seen on the ECG, right? So that is your digoxin effect. Digoxin toxicity is general systemic toxicity. Effect is it is seen in the seen on ECG. What are those? Okay, I should have uploaded one ECG also. Anyway, you will find this very common. Reverse tick sign, that is downsloping of the ST depression, flattened, inverted or biphasic T wave, and short QT interval and PR prolongation. So this is digoxin effect. You got it? The difference between digoxin effect and toxicity. And this is octaplex, that is a human prothrombin complex. So the use is, you rightly mentioned, this contains factor 2, 7, 9, 10 and protein C and protein S. So indications massive bleeding with factor deficiency. Obviously, if the patient is in ALF bleeding a lot, then also you can use it. And warfarin reversal for emergency surgery, because warfarin exactly acts on these. So 20% human, sorry, human albumin. Again, indications, almost everything is mentioned. HRS, large volume paracentesis, in SVP also, then in plasmapheresis, and in case of septic shock also, you can use it for the resuscitation once the hypotension is persistent, even after adequate resuscitation by the balanced salt solution, crystalloid. But obviously, it is not proven beneficial. This is a SAFE and Albios trial. You should know the trials. Again, this is ertapenem vial, and this comes under carbapenem group of antibiotic. Once a dosing is the advantage, but it does not cover Pseudomonas and Enterococcus, because you know Enterococcus faecalis is covered by meropenem. Faecium is intrinsically resistant to carbapenems. Faecalis is sensitive, but this does not cover Enterococcus also. Voriconazole, you mentioned everything what I asked. Azole group of antifungal. It covers Aspergillus and Candida also, but not very much preferable in Candida because we have other antifungals also, which are less toxic. And IV is not preferred because of the cyclodextrin content, which is a nephrotoxic. Good. Now, who will come for ACLS, hemodynamics, and ECG?
Dr. Prithviraj Gauri.
Dr. Prithviraj. Dr. Prithviraj?
Okay, is this the second
No, sir. This is the first
second
one.
set
This
or
is
the
the
first set?
first set, last table.
Last table. So
Yes, sir.
I think what we do, we take a Viva.
Yes,
If
sir.
Darshan and Dr. Pandit is there,
Okay, sir.
one set of Viva and then again go back to it.
Yes, sir.
Let people have an idea of one set of Viva itself.
Yes, sir. So
Okay.
I'll stop sharing.
No.
After this?
After this is your first set has 5 different
Yes, sir.
aspects, right? So
Yes,
this
sir.
is the last aspect.
Yes, sir.
Okay. So we complete this say. So we complete one set of tables itself.
Got it.
So we then will go to one set of Viva.
ठीक है, sir.
And
Got
then
it.
again, we'll switch to one set of the second
Yes, sir.
set of tables itself.
Yes, sir. Yes, sir.
Okay.
Dr. Prithviraj, are you there?
So you have 15 minutes time on this. Okay.
Yes, sir. Dr. Prithviraj?
He's on mute. I think Dr. Gurkirat is again agreed to volunteer, and Dr. Urvi Patel. So I think
Dr.
we can ask Dr. Urvi
Dr.
Patel.
Urvi?
Hello.
Yeah, Dr. Urvi, we will start.
Yes, ma'am.
Your time starts now. So, interpret this tracing.
Yes, ma'am. It's a CVP
Hmm.
and the CVP waveform
Hmm.
has this descent.
Normal, or are you
So,
seeing any problem with this?
I'm sure.
Okay. So, oh, I'm so sorry. Again, I shared the wrong slide. Hmm. What is this? An interpretation of the waveform.
I'm not able to see the slide, ma'am.
Oh, you are not able to see?
Just one
No,
second.
ma'am.
It will just take
It's
some
really
time.
shaky.
Is it visible?
It is going to be visible.
No, ma'am,
I
it's
think you can
showing
just stop,
that
stop and do it again.
Okay. Is it visible now?
yes,
Dr. Urvi, it's visible now?
yes, yes,
Ah.
yes, ma'am.
So, what is the monitoring and interpretation of the waveform? Next.
Some, uh,
Okay. What is this waveform?
uh, arterial waveform with
Which arterial waveform? Which
it's an it's an waveform. It's an IVP waveform,
Okay.
and
Can you see this is normal, or can you see any problem with this? Is it normal or any
I
issue?
think there is an no, ma'am. It is abnormal, and I think it is there is an early balloon inflation.
Good. What is this?
That's an arterial waveform, and
Hmm.
it is showing flushing in the it is a square waveform.
Hmm.
So the first is showing just one waveform after this. So the first is normal. The B waveform is an underdamping, and the C waveform is an overdamping waveform.
Hmm.
overdamped
What is the
waveform.
cause for underdamp?
So, the underdamped waveform can be due to, ma'am, there can be under damping can be due to there is obstruction or there is a kinking of the pipe.
Hmm.
The overdamping waveform can be an air bubble inside the tube or an or a over compliant tubing.
So you're saying over compliant tube. So underdamping you can mention about the tubing. Stiff tubing.
Stiff, yes, stiff tubing.
Hmm. Read it.
Just a minute. 25-year-old male present chest pain and palpitation. Echo was normal. ECG was shown. Uh, there is T1 inversion in V1, V2, V3.
Hmm.
Hello?
Yeah.
And
Anything else significantly you are able to see in all the leads? If I'm giving you the hint along with correlation with this young male
young male with
with chest pain
palpitation.
and palpitations.
Uh, uh, if we can see in the lead, uh, there is an overlapping of this P on T phenomenon.
P on T.
No, sorry. It's
Any comment on this? So you start reading with the basics.
yes,
How is the PR? How is the QT? How are
yes.
the QRS
Uh,
complexes?
the QRS complexes are narrow.
Hmm.
There's a sinus rhythm,
Hmm.
or it can be around 60, 65,
Hmm.
and it's a delta wave.
Hmm.
Um, WPW synchronous.
Good.
Wolf Parkinson White
And
syndrome.
say slurred upstroke is there,
Slurred upstroke,
the
yes.
QRS and almost
Yes.
all the leads.
Hmm.
And along with that, see, PR is very short.
Yes.
PR is short.
Hmm.
What
The
is
following sequences of ECG from a middle-aged patient presenting with chest pain and diaphoresis.
Hmm.
So, this is
What
an
is
ECG strip. There is sinus bradycardia. QRS is narrow, and we can see J point elevation in V2, V3,
Hmm.
V4, and along with that, that's depression in AVL. It's
Hmm.
a lateral wall MI, anterolateral MI.
Okay. So, so which artery is involved here?
LAD.
Any specific comment on this pattern? This pattern? You know the any specific name given to that?
Sorry, ma'am, I'm unable to recall that name.
Okay. What is this?
20-year-old male presenting with seizures, BP is 80/50, and The reason shows tachycardia with broad QRS complexes and
20-year-old with seizures. What all findings you are able to see? How about the explain sign about the rate? How about the QRS
yes,
and
ma'am.
sorry. Anything about any specific comment about the AVR? Sinus tachycardia?
There is a sinus tachycardia. The
Okay.
QRS is broad,
Very
and
good.
there is a
What about this?
there is a QT.
Is this an bolo?
Seems that the patient is having some metabolic derangement,
Yes,
likely
very
to
good.
be maybe hypocalcemia. There
Not
is a
exactly
QT prolongation
hypocalcemia.
also.
But what about specifically? Is this AVR looking normal to you?
No, ma'am. The AVR has there is a reversal of AVR.
So this R wave, is it commonly seen in AVR? Upright R wave?
Hello.
Hello? Is this R wave in AVR, dominant R wave, is it commonly seen?
No, ma'am.
You are right, it is some metabolic problem.
The upright R wave in a young adult can be due to either
Okay, we'll see next. Okay. What is this?
middle-aged patient with chest pain and diaphoresis, BP dropped by 80/50 following sublingual nitrates.
This is the ECG.
Yes, ma'am. There is a ST elevation. It's a sinus rhythm with ST elevation in lead 2, 3, AVF. There are depression in lead 1, AVL, and lead V6. It's basically an inferior wall MI.
Okay, anything adding to that? BP dropped 80/50 following sublingual nitrates. That is the hint.
There's a
Falling nitrates, blood pressure fell down. And based on this ECG, what else you will ask for?
we can ask for a right-sided ECG.
Yes, and
to see
what?
A right-sided ECG to see an
To see?
RVMI.
Yes. So how it is going to change?
Because here we need to give fluids to these patients instead of
yes, because if RV in fact will cause hypotension with
tension. Yes,
venodilators.
venodilators.
In the preload. What is this?
72-year-old female collapses at homes. The emergency services find her unresponsive with no pulse, but the ECG shows the following rhythm. So what will be your next? The ECG has shows bradycardia with a rate of maybe 30, and there is a desynchronization between the P wave and the QRS complex. With the RR interval being regular, it is a complete heart block.
So what is here mentioned? EMS finds.
As she is unresponsive with no pulse, maybe the ECG is showing the pulseless electrical activity.
Exactly. So how you are
The next step
communicate the
will
relative?
be to start her with CPR according to BCLS protocol.
And communication with the relatives?
Uh, Along with the CPR and ongoing resuscitation, will communicate with the relatives in their local language, and will explain them that as she is a 72-year-old female, she might have had a sudden cardiac arrest at her home. Probable reason might be myocardial infarction, and we are giving her the CPR as a life-saving procedure, and to regain the cardiac rhythm, and uh, we will as it
So she collapses at home, right? Out of hospital cardiac arrest.
yes.
So out of hospital cardiac arrest, and after that patient came to the hospital.
Okay,
So
already has come to that.
so definitely you are expecting what? Delayed CPR, right?
Yes, we are expecting delayed CPR. We will explain the complication of delayed CPR, like hypoxic ischemic encephalopathy.
So poor outcome.
Yes,
So this is the CVP tracing, rightly mentioned. We are seeing this A, C, and V waves along with X and Y descent. X and Y descent are sharp. So this is suggestive of pericardial constriction. It's restrictive cardiomyopathy. So what is the monitoring? Anyone can answer? What is this?
esophageal Doppler, no?
Yes. So it is esophageal Doppler. Again for the volume status, and you can see this narrow tracing. So that is decreased left ventricular ejection time, suggestive of hypovolemia. So patient is will be fluid responsive. So this one you identified it rightly, and issue also mentioned. It is IBP tracing with early inflation. You can see it's not inflating at the appropriately at the dichrotic notch. It is inflating early, and you should know the consequences also of the early inflation, right? So this is okay, very basic thing, that arterial waveform tracing, that is a square wave or flush test, and we usually expect that it will come to the normal in 1.5, after 1.5 vibration. But if it is taking more than that, it is under damp, and if it is taking less than that, it is over damp. So you should know the causes for this under damp, like very stiff your lines are there, and if you are finding any uh, uh, in fact, if the patient catheter is moving also, then also you can find under damp, over damping, air bubbles, any clot is there. In fact, if your bag is also getting deflated, that can also cause under damping. So this is, if you are reading an ECG, then you have to mention, start with the rate, rhythm, and then see all the complexes: P wave, QRS complex, PR interval, QT interval, and T wave. So if you will make this a habit now, then you will not leave forget anything, and any ectopics are there. So you can see here PR interval are short, and there is a very nice delta sign, that is the slurred upstroke of the QRS. So classical of WPW syndrome, along with the history of young male presenting with chest pain and palpitations. So this is anterior wall MI with the LED occlusion. This sign, this is J point is elevation and ST elevation with biphasic T wave, up and then down. This is Wellen syndrome. So this is suggestive of proximal LED occlusion. Definitely he has to go for PAMI. This is 20-year-old male presenting with seizures and BP is 80/50. Drop in hypotension is there along with that seizure. And you see this Q and T, P and T are also very small. Along with that, there is broad QRS complex is there. Broad QRS complex plus positive R wave in AVR. That is hyponatremia. Patient is having sodium channel blocking. Not hyponatremia, sodium channel blocking, then overdosing, then you can see these kind of ECGs. So here it could be because of the TCA poisoning or excess lignocaine, local anesthetic poisoning, or your antiarrhythmics, because they all act on this sodium channels. So overdose of that also can cause this ECG. So answer here is anyway TCA poisoning, TCA overdose. Now this one, rightly mentioned, again, read the ECG in that way only. So there is inferior wall infarct because ST elevation in 2, 3 and AVF, always along with the reciprocal changes in the lateral walls. Always in case of right inferior wall MI, ask for the right side ECG to rule out RV infarct, because we know that there is a difference in the management. As RV infarct, you should adequately fill the patient. Patient should not be preload deficient. Otherwise, hypotension will happen. That's what happened with this. And nitrates are contraindicated in these patients. You can get an idea of RV infarct seeing this 12-lead ECG also. Criteria, there is some criteria, that is ST elevation in lead 3 is more than lead 2, and there is slight elevation in V3, V1, V2, V3. So you can get an idea about it, that there looks like RV infarction. That can be easily proven with right side ECG and 2D echo. So this is female collapses at home, unresponsive with no pulse. So this is pulseless electrical activity. Our next step is CPR, but definitely we have to communicate with the relative because the patient has collapsed at home. 72-year-old female patient, we are expecting some downtime. So outcome may not be very great. Okay, this one a question was left, sorry. So this is 60-year-old male suddenly collapses at work. Bystanders witness the event and call 911. When EMS arrives, the patient is unresponsive, not breathing, and has no pulse. So what is it, Dr. Urvi?
The A shows an asystole, but when we are increasing the
So
gain,
this,
we can
yeah.
show small ventricular fibrillation activity. So actually, we need to give CPR to this patient before declaring the patient, because it can be a
asystole में
pulseless
भी तो आप
electrical
CPR
activity.
दोगे ही ना?
No, no.
asystole में भी तो CPR
Yes,
दोगे
yes.
ना? So what is the difference between the two?
So, ma'am, maybe before मतलब asystole के हमें asystole prove करने से पहले we have to increase the gain and see, because sometimes we are not able to see the
Yeah, but what is the
low
difference
voltage.
between but what is how your management is going to change here? What most important thing you are going to change after seeing this ECG? Dr. Urvi, this is
Yes,
that
ma'am. In the
is
asystole, there are chances that we cannot achieve ROSC, but in B, the cardiac electrical activity is still present. So,
Urvi,
uh,
there are
yes,
two
ma'am.
kinds of rhythm in cardiac arrest, right?
Yes.
What are the two kinds of rhythm?
Okay.
You
We
can't
have
miss this. This is very important.
shockable rhythm and non-shockable rhythm.
Exactly. Don't take this
Yes.
time for this. So
Yes. Yes. Sorry.
what you will do here?
So, in B, we need to go for defibrillation.
Yes. Okay. Thank you. Good, Dr. Urvi. But
Thank you.
definitely there is always a scope of improvement, but a good
Ma'am,
attempt.
can I ask one question?
Yes. Yes.
Ma'am, in pulseless VF or VT,
Yeah.
we will go with CPR or shock? We'll go with
No.
CPR,
We
right?
will start CPR for sure. But in case of seeing the asystole, you are not going to give shock. You are not going to use defibrillator. But if there is a
Okay.
VF, then start the CPR. But then you have to give the shock also, na?
Ma'am, if pulse is not coming after CPR, then also we have to give shock
Of
in
course,
pulseless VF.
if it is VF, you have to. VF
Ma'am,
में pulse नहीं
asystole
रहेगा.
and ma'am, asystole and pulseless VT-VF is non-shockable rhythm.
Not at all. It's two kind of rhythms: shockable rhythm, non-shockable rhythm. Non-shockable rhythms, why it is divided into two? Because shockable rhythms, there is a very not very good, I'm saying ki all patients are coming out, but there's a good chance that patient will come out once there is a possibility that rhythm will get stored. And these are shockable rhythm because they might respond well to the shock, okay, with a good outcome. Non-shockable rhythm, so shockable rhythm comes ventricular fibrillation, and because ventricular fibrillation is always pulseless, no need to mention pulseless ventricular fibrillation. And second is pulseless ventricular tachycardia. Okay. Non-shockable rhythm will be two rhythms, asystole and pulseless electrical activity, where there is no role of shock.
Okay. Okay.
Got it?
Yes, ma'am. Okay. Thank you.
Can't miss this answer, okay? And can't you have to read each and everything about ACLS. These things you cannot miss. And ACLS table is at times your deciding table, okay? I'm done, sir. Ma'am, Darshana ma'am, are you
Yes, Ritika,
Ah.
I'm here.
there? Please start, ma'am.
Thank you. Arindam, shall I start? I think he's gone somewhere. Arindam, Ritika is done, so can we start with my session?
Yes, Darshana,
Yeah,
Dr. Pandit is in a parallel program. So what I would ask you is that Dr. Paresh is here. So you
Paras is
start
here.
with the, you start, Dr. Pandit wants to join for the review paper and as well as the thesis. So let's start with the quality and clinical audit, and that by that time he will also join.
Okay, so I'll finish with communication and quality, right?
So, and your time is, I think, 10 minutes per table, per
Acha,
Viva.
I had one query. I was asking Sudeshna, so I'm
Just
asking
let
you.
me see on this. Yes, please. Query you are saying.
You're saying 10 minutes per question or 10 minutes per session?
Let me just see. I think this is 10 minutes per segment.
Per segment?
No, sorry, 15 minutes. It's fine. 15
Yeah.
minutes per segment. So
Okay.
one entire Viva comprising of 4 which is your literature review, evaluation of the thesis, communication, legal and ethics, and audit, safety and quality. So these are the 4 components. 4 components will need 15 into 4, 1 hour.
Okay.
Is that okay with you?
Yeah, so like for the communication, I made 2 set of questions. For quality and all those parts, again 2 set of questions, which are a mix of all this.
No. 2 sets. You have to do 2 different sets. Na? So 1 set of Viva will have 1 set, and the second communication you will do in a separate set.
So that when I will do, immediately or afterwards?
No, you do it afterwards. So 1 set means 1 set of communication, 1 set of quality, 1 set of
Okay.
thesis and A. So to all the candidates, 2 of the volunteers, you have to come up forward with your thesis paper, right? So here we will ask about your thesis and we'll very quickly assess your thesis. So first 2 minutes, quickly you have to tell what is your thesis about, a little bit of A, and then we will ask certain A. In actual exams, your thesis paper would be taken over by the examiners. They will go through it and then ask questions. Here in the demo, we will quickly try to assess quickly what is your thesis paper and ask certain questions which are standard asked by the examiners itself. Okay. So I would request 2 of you who are confident about that A, right? So you have to come up with your thesis and we won't go through it. We will ask certain questions about in 2 minutes and then we will poke deep into, we'll dig deep into your thesis itself, right? More of a theoretical question. So let's start, Darshana.
Yes, I'm sharing the PPT.
PPT. And
Shall I
one
share
more,
it?
that please do not because do not put it in the chat because that becomes almost a prompt. In actual exams, you won't get a prompt itself, right? So hold on to your to your excitement or whatever. Do not keep. Once the question answer is over, you can give answers or ask questions on that. So Darshana, over to you. Start with, I think, quality, then communications. By that time, Dr. Pandit will also join.
Okay, fine.
And Dr. Paras is going to support you on this.
Okay, and
Dr.
the briefing
Paras, you are here?
Last question.
Yes, I am around. Yes,
Yes,
Arindam.
thank you, sir.
And the last question is that the briefing will be after each session or after the entire session?
Now, briefing, I think briefing should be done post 1 session. Let's do it here because it's a complicated one. Briefing all the 4 after 1 hour, it will get botched up. Let's do the briefing after 1 segment.
So Arindam, you're around when I start with, and then we will just go through. If you have anything, if I have any doubt,
I will
ask.
add. I will
Can you
definitely.
see
I'm
the
here.
slides now? Is
Yes.
everyone able to see? Okay. Now, are there any 2 volunteers or how is it?
Yes, volunteers will come forward. Sudeshna is going to coordinate on that. Sudeshna, get 1 volunteer, please.
Please type in the chat box whoever wants to volunteer, or we would have to choose somebody.
Because once I share it, I won't be able to see them.
Yes.
Actually.
Anybody would like to volunteer?
Volunteer for the communication, medical, legal, and ethics. If not, in another 30 seconds, Sudeshna, you pick 1 randomly.
Yes, sir.
You have 78 people.
Sir, I could volunteer, but my mass chat box is disabled.
Gurkirat is enabled right now.
Gurkirat again?
Yes, sir. I'll try.
अरे गुरजियो, तुम लोग क्या देखो गुरकिरत बार-बार सामने आ रहा है.
No,
बाकी
but
लोग
if
देखो
they
आप
will do
लोग
like this, they will not get confident for the exam, no?
हाँ,
Sir, actually, I am most scared about practical only because I'm not good at it. So I'm giving my best shot today. Yes, sir.
ठीक है, गुरकिरत माउंटेन ड्यू पी रहा है. डर के आगे जीत है, आ जाओ.
Chalo, let me know when to start.
You can start. He is ready.
Okay, so here is the case.
Yes, sir. Yes, ma'am.
So you can read the case.
A 47-year-old male, case of diabetes mellitus, admitted with acute stroke due to IC bleed with midline shift, underwent decompressive craniotomy, hemodynamically stable on a ventilator, absent brainstem reflexes. Questions on
Right.
communication.
Now we come to the question. So I'll ask you the first question. How will you communicate the prognosis and possible outcomes effectively to the patient's family while ensuring clarity and compassion? So this is the patient who is there, and now you are supposed to talk to the family. Okay. So how will you communicate?
Ma'am, I would like to.
The patient has a wife and a son. The son is around 17 years old. Patient has a wife and the parents.
Ma'am, I would like to use the spike protocol for communication here. I would set choose a comfortable environment for talking to the family. I'll try to perceive what already they know about the situation, about their patient, that he is
So,
brainstem.
okay, now let us do one thing. Okay, Dr. Paras is there. I am there. Okay. So, Dr. Paras is just behaving as one of the family member. He's the brother of the patient. Now you can start, and there are the other family members. Now you're talking to him. So, you just talk in the way you would talk about his patient. How would you communicate? Paras, you are around, right? Paras? Paras, you must be not mute. Paras, can you hear?
Yes.
Dr.
Yes.
Paras?
Yes, I am around. Yes.
Yes.
Okay.
Good
So,
evening, sir.
Paras, you behave as the relative
Yeah.
and he's talking to you. Okay.
Yeah.
You are the brother and there are the parents and the wife and one son. Okay. Go ahead.
Can I see the case again, madam? Once
Okay.
more, the back.
47-year-old male, case of DM, admitted with acute stroke due to IC bleed with midline shift, underwent decompression craniotomy,
Yeah.
hemodynamically stable on a ventilator, absent brainstem reflexes. Okay.
Thank you.
So there are these questions on communication, legal, and ethics.
Yeah.
So first question is, how will you communicate the prognosis and possible outcomes effectively to the patient's family while ensuring clarity and compassion? So he is going to talk to you. You are the relative, and he is the doctor communicating, the ICU critical care physician. Go ahead.
Yes. Good evening, sir.
Good evening.
Sir, I would proceed, sir. I would proceed in the vernacular language of the patient and
Yes.
try to communicate the possible outcomes. And I will tell them the prognosis, but I would try to first of all set the situation and choose a comfortable situation to talk to them, perceive whatever the knowledge they already have on this subject, invite their questions, and respect those questions. Try to understand on the knowledge they already have and build upon it, and then spikes protocol emotions, and then summarize so that it should not be very long.
Okay. So what you will tell now, this condition which you have been given to me, what you will tell to me?
Suppose,
So,
okay, he's understanding English, so you speak in English. Come on. Making
okay,
it.
I would say, sir, that your father was a very good man. He lived a very good life. He did a lot of good work. We are here to help you out in this difficult time. I would like to you to understand first of all, I would try to understand what knowledge do you know about your patient sickness. Do you have any idea what has happened to sir?
Yeah, so he had a bleed in the brain and had a surgery after that, and
Okay,
he's
sir.
on the ventilator, and
Yes,
he's
sir.
not doing well.
Yes, sir. So that is what you already. I would like you to understand that the prognosis here, that his chances of making out or going home are very less, and his brain is not his brain the if the since his uh, brain is not since his brain is not working. I'll try to go to the vernacular language that I will. He may not recover from this situation, and we could think ahead of end of life care, that we make him as comfortable as possible, not go for any invasive procedures or anything other, because that is all going to be a futile effort to save his life now. And we can even think of organ donation. Yes.
Yeah, so you will directly approach for organ donation,
No,
or
no, no. I will not. I will try to build up first of all.
Paras, we will tell him later on the feedback. Okay,
Okay.
you go to the next question. What legal
Yeah.
considerations should be considered regarding decision making for a patient with absent brainstem reflexes, especially concerning end of life care?
The legal considerations to be regarding decision making for absent brainstem reflexes. The biggest decision here is when to forego the life support here. When are we supposed to withhold or forego the life support, sir? I want to talk to you about that, because there is all the efforts are going to be futile now. We cannot get him back to a situation where his life can progress. The
So
so
1 minute, this you can just tell me when you're not talking to the patient family. You tell what are the legal considerations as a physician who is in the ICU that you need to consider regarding the decision making. Your communication part is over on the first one where I asked you about the prognosis and possible outcomes. Now, there is something where we need to take a decision regarding to the patient with the absent brainstem reflexes. So first and foremost, what are the things that you will think of with your team, which are very important legal considerations? Did you get
um,
my question?
I'm trying to understand. I'm getting around it, ma'am. That the legal considerations will be because there will be the conflict in understanding, because the brainstem reflexes are not there. The legal consideration is when to forego the life support here,
Hmm?
because brainstem reflexes are not there. The second consideration is whether relatives want to go for organ donation, or whether we should consider for organ donation is if the patient is uh, candidate for that. Other legal considerations are that uh, uh, there is difference of opinion. Some physicians may think to still continue the treatment, while since the brainstem reflexes are not there, so uh, there is no point of moving ahead. Because there's a difference of the opinion. So these are the legal considerations. There's proper documentation is needed for this. First of all, we'll have to confirm the brainstem. We have to understand that there are no confounding factors. That there is no sedation, paralysis, other causes of encephalopathy are ruled out. Then all the brainstem tests are done. The reflexes have been checked. The cranial nerve examination has been done. Apnea testing is whether it is documented or not. After that, we can go for legal considerations.
Okay, third question. How should ethical conflicts be addressed if the family has differing opinions about the treatment continuation? So, there is a difference of opinion. Some of like three people are saying continue, two people are saying stop it. What will you do?
Uh, the most important thing here will be, first of all, documentation, understanding that who are the blood relatives here, whether and who are directly responsible for decision making, and all
Yes.
five, since all five cannot come in consensus, uh, the or first of all, the thing for us to know is that, say, if no one can come under consensus, then we cannot go ahead with foregoing of life support. Even if
Okay.
one person is not in consensus, we cannot go for life support. And we have
Okay.
example of that, like that of Aruna Shanubag case.
Yes.
Yeah.
Okay. Without an advance directive, how will you and your team navigate surrogate decision making and obtain informed consent for further interventions or withdrawal of care?
Since advanced medical directive could have been helpful here, but the problem is that it has got a very cumbersome way of the ethical position have also challenged that advanced medical directive. So since it is delaying the life support, since it is delaying end of life care, so here the problem is that end of life care is going to get suffered because there is no proper consensus. So our team will navigate in that way that we can get all the relatives to understand the process of end of life care. First of all, uh, what is the end of life care? What are we going to do? What get consent of the relatives that we have to forego.
The appropriate manner.
हाँ भाई
Uh,
Have you done this anytime in your
Ma'am, we have done this, but not very often. So
anyone
that
else
we
wants
have
to
written it.
volunteer for this?
We have written. I've read about it in theory, but not and prepared it also,
So,
but not able to get the practical.
okay.
The possibility of organ donation will have to be undergone after the committee has to go. It consists of 4 doctors, so all 4 will have to document and come to decision of brainstem death, and then it shall be narrated to the family, and they have to come in. Though we don't need family's consent, if for but if there is a conflict, then we have to get consent here.
Okay. Related to spikes, you said something about spikes, no? So what is
Yes,
that spikes? What does S stand for? What does P stand for? Any idea?
yes, ma'am. S is for setting.
Hmm.
Choosing a appropriate place and position so that we can talk to relatives.
Hmm.
Comfortable environment. It is related to environment.
Hmm.
Uh, P is related to perception, perceiving what all the knowledge relatives already know and how to build upon that knowledge. I is for invitation, asking the questions, inviting their questions, and respecting their questions, whatever they have issues. K is for knowledge. What uh, uh, we have to explain it to them, the disease process, the irreversibility, the reversibility. Uh, S is for summary, and E is for forgot now. Likes
E is for emotion.
emotion. We have
Yes.
to understand their emotion.
Emotion and empathy.
Empathy is empathy for end of life.
Yeah, so that is something which is very important when we are doing. Okay. Arindam, shall I discuss on this now only or should I finish the second set also? Arindam?
I think we'll finish this set, madam, and then go next one.
I know he's there or no, I don't know. Okay. Uh,
Arindam is on the phone.
I think anyways, chalo.
If
So
anything,
see, you have answered few things which were
Yes,
right.
ma'am.
Paras, you want to add or shall I speak first or and you will
It
add
is
few?
very tough, ma'am. This is the most tough.
Yeah, so this is the most toughest, but this is also the most common which we come across in the ICU. And communication is something which we all need to know. So, in the very first question, this is a patient who is, if you really go to see, this is a young patient who is a 47-year-old who has a family, who has parents, and has had a bleed and has undergone a surgery, but not good, though he's stable on a ventilator, but with absent brainstem reflexes. Now, you always need to understand that there are two things into this. One is about the communication with the family, and second is on the further, whether there is a de-escalation, or whether there is a end of life care, or whether there is a withdrawal of care, or if there is something about a organ donation. So there are multiple aspects attached to this case, and we come across this quite commonly. So, how will you communicate the prognosis and possible outcomes effectively to the patient's family while ensuring clarity and compassion? You started it very well by saying spikes, okay, but you should have just actually told everything about the spikes at the same time. So, you just ended up just saying about the setting, and you told about how much do they know. You will first tend to find out. So, if you have to answer in this, you have to say that first and foremost, I will see to it that who are the people in the close next of kin to the patient, like the wife, the children, the parents, would want to call all of them, make them sit in a room where they are comfortable. I will also sit in the room with them, sit across them, and then I'll start the conversation. Okay, and then understand how much they know, then give them your 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 scenario of what are the things which are expected, and then give, tell them about the disease, that in this case it is very clear that though he is on the ventilator, he is breathing at present with the support of the ventilator, his vitals are maintained, but overall his condition is not great, that he will come home walking or he will be awake at any point of time. This is very clearly to be told to them. Okay, and then obviously there is a family who is going to bring the patient to you. Now need to see, and I have to do this in a very empathetic way and ensure that the family understands at the same time. Paras, you want to add anything on this first answer?
I think no, that is nothing to add. I think appropriate. I think gathering their information and then providing what is the update, telling them the course, and then what is the likely course of action from here onward. Just follow the spike model.
Yeah, so he started with spike. He could have
Mm.
just elaborated on the spike at the same time. Then is the second question: what illegal consideration should be considered regarding decision making for a patient with absent brainstem reflexes, especially concerning the end of life care? So here in legal considerations, first and foremost is that you this is a thing which you spoke about, that there are two things in this, as well as when we are talking about the brainstem death. So testing also, it is very important that all the team members are in sync about what is happening with the patient. Maybe a neurologist, it may be a neurosurgeon, it is the intensivist. We all have to be in sync. There might be a primary physician, or maybe just a physician under whom the patient is admitted. You all have to be on the same page, because if even one has a little doubt, it is going to be a haywire thing. Secondly, uh, end of life care is not so easy to speak about, especially for a patient who is at this age. So you will not talk about end of life. This is what Paras was trying to ask you, that at that point of time you will not be the first person to bring it up across to them. Okay, most of the times nowadays it happens that the family comes across, right? Paras, anything you want to tell over there further?
No, I think having a consensus within your team members so that everyone talks the same language, physician, nursing team, everyone understands patient has potential brain death, and then or brainstem reflex absence, and then whether to go ahead with the brain death testing. And you can clarify when you are communicating with this patient, like your loved one does not have a brainstem reflexes. I'm concerned about that, and possibly we will be doing some more tests. to determine whether there is any presence of brainstem reflex, and you can explain the implication at that time. But yeah, legal consideration, again, achieving consensus is very important. Having a different messages to the family is not good news.
Yeah. Then the ethical conflicts to be addressed with the family with differing opinions. This is something which again we come across in our day-to-day day-to-day management also. As you very rightly said over there, that even if one of the family member is saying no, then we should not be going ahead. That is it. Everybody, the entire family member should be in consensus. And also ethically and legally, it is very important that the signatures that need to be done have to be done by the next of kin. So if it is a wife, if it is the parents, so everyone's signature has to come. Or if it is a elderly person who is not having a wife but has only children, the children, all the children, even if the children are not here, you have to ensure that you get the signatures from everywhere. Okay, so that is very important, because someone may just stand up next time and say that, I was not involved in the decision making. And another one thing is that you need to see to it that when you address, even if people are outside in this today's world, we have a lot of network options to get the people in one conference room and take them on video when you're talking about this, so that everything is very clear, and there is a recording also which is there, which is kept. Okay. Then, without an advance directive, how will you and your team navigate decision making and obtain informed consent for further interventions or withdrawal of care? You already spoke something about it, which was there. Paras, you want to answer this?
So I think without advance care directive, for a withdrawal of care, you again speak everyone in the room, discuss what are the most likely outcomes in this situation, and then put them give them options, whether continue care, not for escalation of care, or or withdrawal of care. And based on the discussion and consensus achieved within the family, you have to progress. Withdrawal of life support, again, based on the which state you are in and whether it is allowed legally, that needs to be kept in the mind.
Yeah, that is very clear, because you cannot disconnect the
Darshana,
ventilator.
I'm interrupting. Dr. Pandit has joined. So I am very tempted to ask him about this aspect, because
Withdrawal
I
of care.
think Dr.
Yeah.
Paras very recently shifted from Australia. So, and things are a little different over here. I think, sir, if you
Yes.
can give us a very quick review of all the candidates, that what they should, advance
Okay.
directives, withdrawal of
So I
care.
think Sir can even discuss on the organ donation to be discussed. He does it very well with the family, actually.
So these two, very
So,
quickly, sir.
so I think let's answer this first question, which is withdrawal of care in absence of an advance directive. Now, there are two aspects of this. If you have already declared a patient brain dead, tests have happened in the way officially described in the Transplantation of Human Organ Act, and you have declared the patient brainstem death by the second apnea, then ideally you do not have any problem if the family has accepted the death has happened. The family accept the brainstem death as a criteria, that they are accepting that there is a death now with the of the patient which has happened, and he's not likely to come back. In that case, you can actually withdraw the patient's ventilation. You can withdraw the inotropes. You don't need any legal support for that. It is absolutely fine. If you're dead enough to donate, you're dead enough to disconnect. That's the ethos behind it. Of course, you may have ill-informed administrators, you may have ill-informed colleagues, you may have ill-informed seniors who would put up a obstacle and say that this is not correct. But remember, you have declared the patient dead, and you are only stopping the ventilator on a dead patient, not on a live patient. So legally, there is absolutely no problem. But I can understand, because of the peer pressure from the hospital not being supportive. If the family is on your side, they have understood that this patient is no more, then what I usually would suggest my colleagues, my junior colleagues, is just tone down everything. Bring down the F5 to 21%, bring down the inotropes to the bare minimum, bring down the respiratory rate to 8 or 10, and let a cardiac standstill happen. That's the other way of actually allowing a circulatory standstill to happen and then hand over the body to the patient, to the patient's next of kin. However, you would not be actually getting into that kind of a situation very often. You would actually have a situation where you may be asked that should we be able to withdraw patients from life support or not. Now, it's important to understand that in 2023 February, there was a judgment by the Honorable Supreme Court of India. That case was Common Cause versus the Government of India, where IICCM was one of the partners of that, and Palliative Care Society was one of the partners of that, and Society of Neurology was one of the partners of that. All these three petitioners actually petitioned for that petition, and the court gave a decision that yes, withdrawal of care in case of futility in the patients who are terminally ill and not likely to make a recovery is possible in India now. They have put up the judgment into a very elaborate process. The process described here is of two medical boards. So if a patient is there in the hospital, not necessarily brain dead, but patient has got a very terminal illness, not likely to make it, family agrees that this is a very poor prognosis, or the physician feels that this is a very poor prognosis. And when I say physician, I mean the primary admitting doctor, I'm saying. Either of them can actually request for a primary medical board to be formed. So the family, if they feel that it is not appropriate to continue therapy because there is no outcome, and the physician agrees to that, then physician can actually call for a primary medical board. The primary medical board consists of 3 people. As soon as the request comes, the hospital administration, which usually is the medical superintendent or the medical director or the CEO of the hospital, would formulate the primary medical board. Primary medical board has the primary doctor under which the patient is admitted, plus 2 other doctors of the relevant specialty under which the patient is having the main problem, with at least 5 years of experience. So 3 doctors in total. One is your primary doctor, 2 are your other doctors from the same hospital with 5 years of experience. They are supposed to give their opinion within 48 hours. So they will come, they will talk, they will discuss the case, they will examine the patient, and they will then discuss their findings with the patient's family after they have concluded their findings. And if their findings say that this is a futile case and withdrawal of life support can be a life-sustaining therapy, WLST is what we call it. Withdrawal of life-sustaining therapy can be fully advised and the family agree to it, then the hospital administration formulates the secondary medical board. Now, this is where the government has put the rules a little bit more stricter. In secondary medical board, none of the doctors from the primary medical board can be a part of the secondary medical board. So there are 3 independent doctors in the secondary medical board. One of the doctor in the secondary medical board has to be nominated by the CMO / district health officer / civil surgeon or the director of medical services of the state government. So for example, in Maharashtra, it is the director of health services in Maharashtra, which actually formulates this appropriate authority is what is called as. In some district, it would be the district surgeon. In some districts, it would be the chief medical officer of the Zilla Parishad. So whoever is the appropriate medical authority in that district, they will have a list of doctors who could be a part of the secondary medical board panel, and the government will appoint one of them. That the government will appoint a whole list of doctors, and the hospital will have one of them chosen up to actually represent on the secondary medical board. That doctor can still be a part of the same hospital. He need not be a part of an independent hospital. He can be a part of the same hospital as well. So what Karnataka government did very, very recently, for around 4 weeks ago, that we already have a brainstem death committee, which is approved by the same appropriate authority. And we have doctors who are approved for the brainstem death to actually do a brainstem death testing in our hospitals. A lot of the hospitals who have got transplant or who are NTORCs have this provision. So the Karnataka government requested that these doctors who are nominated already by the district health officer or the appropriate authority can be a part of the secondary medical board. So they have actually paved a similar thing to be continued in all hospitals wherever there is a brainstem death committee. The Maharashtra government has extended the similar process for government medical colleges, not for private hospitals yet. So I think it's still work in progress. So once primary medical board is completed, secondary medical board is formed. One of the doctor becomes a part of the process who has been nominated by the appropriate authority, and then two other doctors with 5 years experience in a similar specialty. They all three come together, again examine the patient, look at the history, go through all their opinions, and if they also concur that yes, futility is there and you should be withdrawing care for this patient, in that case, they have to inform the district first class magistrate. District magistrate first class is what actual word is in the judgment. You are just informing them that so and so patient, primary and secondary medical board was formed, and now we are going to withdraw care in this patient. You don't have to wait for their consent. There is no permission required from the district magistrate. It is just an information, and that information goes through the hospital. The doctors don't have to inform. Doctors have to write their findings. They have to discuss their findings with the family after each board, primary as well as the secondary board. And after the secondary board, withdrawal of therapy can happen, except that the hospital has to send an intimation to the district magistrate. So this is the current rule, absolutely legal in India. Lot of states have not adopted it. Maharashtra and Karnataka are the only two states adopted it. Karnataka has done it a little bit more in a polished way. Maharashtra has just left it off for the government medical colleges, whereas Karnataka has it now equal for government and private medical colleges. Eventually, I believe hospitals will have specialists nominated by the government who could represent on the secondary medical board, and they would be able to formulate a secondary board very quickly. Both the boards have to give their findings within 48 hours each. So first board has got 48 hours to give their findings maximum. Second board has a 48 hours finding as well. So if you had a secondary board person in your hospital, you could pretty much complete the whole process within 1 day. It shouldn't take too long. But a court has given you ample time for the doctors to actually do this. Now, the best part of this judgment is there are 6 independent doctors who are judging this. There is a full immunity to one doctor, so there is nobody, one person who is making the decision. The family also feels that this is excellent. There are 6 independent specialists who have come and examined, and they all concur. The hospital also gets a lot of immunity, that there are 6 people who have come and concurred, and the decision is a shared decision. Hence, I think this is one of the best judgments which has been given by the government, by the Supreme Court. Please have your states adopt it, and then I think after we do hundreds and hundreds of withdrawal of life care because of futility, like it is done in the Western world, where there is absolutely no way these patients are going to come out of the ventilator, but we still keep on ventilating them till the heart stops. Maybe there could be some dignity of dying, dignity of death, which could be provided to these patients. And this is exactly what we are talking about. We are talking about withdrawal of care in those patients where futility is definitely there. And once you prove it with 6 doctors, I think the decision shared is better way of going forward. So that's the current law, Arindam and Dr. Darshana and Dr. Paras. We can the law is currently valid in Karnataka and Maharashtra. In Maharashtra, in some certain places only, medical colleges, not everywhere. And because health is a state subject, each state has to adopt the law. Unless the law is adopted, it cannot be sort of implemented into a broader sense. But remember, it is the Supreme Court of India which has given this judgment. So every citizen of the country, this law actually is required to be implemented. It's just the apathy of the places to not implement them. But once the Supreme Court gives an order, it's just a matter of process for this to be implemented. There's no argument that there has to be a change in this, unless it's challenged again by somebody in the Supreme Court. As of now, there is no challenge in this. Thank you very much. I'll be happy to have any other questions on this if you have, or if you want me to answer some other question you had asked me, right, Dr. Darshana?
No, this were the 2 parts. I think this is the first part of the communication first case that we did. The second part was about going with the thesis, which any student who is wanting to just volunteer for the thesis, then we can go ahead with the thesis questions. So there are 5 questions on thesis. Anyone who will volunteer?
No,
and just
there was a question about communication with brain dead you asked me, right? Something like
Ah,
that.
sorry. That was about how do you explain to the patient family on doing a brain dead
There
test.
are
It's a very
two,
important part.
yeah, there are
Yeah,
two
I will
buzzwords.
just interrupt, sir. By that time, we need one volunteer with the thesis itself and have a synopsis of your thesis. Dr. Pandit, Dr. Paras, and Dr. Darshana will listen to your thesis. You will have 2 minutes to explain about it. And then there will be certain questions on the thesis itself. So please,
Yeah.
someone come forward, or we can't take this. We have to skip this entire session then, otherwise. Over to you, sir, please.
Give me just 2-3 minutes to explain this. I think this is a very important point.
Yes,
How
sir.
to communicate brain death and how should the patients actually understand, the patient's family understand that their loved one is no more. So obviously, I think Dr. Darshan has already covered a lot of it, and Dr. Paras has also covered a lot of it. I was listening to parts of it, that the setting should be in a room. The room should be a non-confronting environment. Usually, you should not sit on a table across each other. That's a very confronting environment. Usually, you should either sit on a round table so that there are no corners there, or you should sit at right angle to each other. When you talk to the patient's family, you should be able to look into their eyes, have eye-to-eye contact, and able to speak and express yourself quite clearly. What I usually do is when I do a brainstem debt testing, I actually go through the entire test with the family even before we have done the testing, and I invite one of the family members to come inside and watch me doing the test. And most of us are very comfortable, at least in our unit, most of us are very comfortable doing the testing in front of in presence of the family member. But let's say the family members have not watched it and you are actually explaining them after you've done the test. So the way I would break up and I would say the conversation is I would introduce myself. I would come to know who are the family members who are actually there, identify the next of kin. Next of kin in government legal language is very clear. So spouse is the first next of kin. In case of children, it is the parents who are the first next of kin. If spouse is not there, then children or parents of that person can become next of kin, and so on and so forth. Then grandparents. So I think the next of kin is the most important person. In Indian scenario, you would always have an elderly member of the family who would be very well respected, and they would actually place them as a next of kin as well. But make sure that when you're doing this brainstem death declaration, you have the next of kin present. It makes your job very easy, and legally also it is very good. What I explain to them is I explain them the testings which I've done, and I tell them that look, there are two things which you should be aware of. First and foremost, that what is what is life? When does the life happen and when does the death happen? And usually I would ask them that, do you celebrate the, I would ask them that what happens when the heart first starts beating into the child, when the baby is in the mother's womb, in the mother's uterus, around 7th to 8th week, you can actually see on an ultrasound or you can hear on a stethoscope the baby's heart beating. So do we celebrate our birthday on the 8th week of gestation? Nobody does that. We do it when the baby is born. What is the big difference when the baby is born? The baby's heart was beating for almost 30 weeks before that. The difference is the breath. When the baby is born, you take the first breath. That is when you say that the person is alive. So, person is death when the life is gone, when the breath is gone, when the breathing is gone. And that is what we are testing with the apnea test. We are testing whether the patient is alive or not by testing whether the patient has the capacity to breathe or not. And what was happening in the mother's womb? The mother's circulation was supporting and giving oxygen to the baby. Here, the ventilator is doing the same job. So it's just an artificial support, which is just pumping oxygen in and out. But the patient does not have any breathing capacity. The heart is only continued because there is an artificial oxygen being pumped in. And if the ventilator was not there, this patient would have a cardiac standstill in no time. I think that is the most important, first important thing that I talk to them. And quite often I see that the penny drops for them. They are very clear that this has happened, and they would not have any doubts in their mind about the brainstem death after that. So that's the first thing which needs to be declared, discussed very clearly. So this is the buzzword which I use, and I would not say he's no more by his brain that are very, very actually talk about for organ donation.
Any questions from any of the candidates or participants? Any clarities that you need?
As of
Okay.
now, none in the chat box.
No.
But Gurkirat has volunteered for the thesis. So you can come forward and
Sudeshna Gupta is ready to volunteer for thesis also.
okay, then let us give Sudeshna first chance because Gurkirat already have done. In the next round, there will be one more. Gurkirat, you be ready. Okay, so Sudeshna, very quickly to all our faculty member, if you can present your A very shortly, in a very precise and concise manner. Are you ready?
Thanks.
Yes, sir.
Okay, so present your thesis. What exactly
My greetings to
you
all
can
the
do an
respected
abstract to your
faculty.
submission.
Myself, Dr. Sudeshna Gupta. My thesis title is A Comparative Study Between the Dexmedetomidine and Fentanyl as Sedation for Facilitating Extubation in Intensive Care Unit. As we all know, sedation comprises an important part for the ICU patients who are on mechanical ventilation. And every ICU has their own ICU sedation protocols, but using drugs like opioids and benzodiazepines has been in use from previous times. But such drugs have their own side effects as well, especially in relation to the hemodynamic instabilities and the comorbidities like concurrent liver and renal associated comorbidities what we get in the ICU patients. So coming up with another recent drug in vogue, which is alpha-2 agonist, dexmedetomidine, which can also be used in ICU sedation, which can be used to maintain a good RAS scale and can also be found effective for extubation properties as well. In our study, we have done with a sample size of total 60 patients divided in two groups. Fentanyl groups, we have chosen the fentanyl, the most common opioid that is used for ICU sedation with 30 patients, and another group, dexmedetomidine group, the alpha agonist group. The patients were
Krishna, wait, I will go ahead with the questions. Arindam, shall I start with the questions? Because I just wanted a brief of what was the thesis. Okay, so I think you first question is what inspired you to choose this research topic and what problem does it address? You were just saying that in the previous this thing you had just told it. So can you just put it crisply?
Madam,
Sudesh.
because till now, most commonly the opioids and the benzodiazepines has been in vogue as the ICU sedative agent. But in ICU, we often see such patients who doesn't require the ventilation for too long, or they doesn't require very high sedation score based ventilation. Right? As per like some sepsis patient, they can be easily maintained on mechanical ventilation with a RAS of -2. And such benzodiazepines and opioids, they are primarily metabolized by the hepatic system. Their dependence on the renal clearance, and they are also dependent in deepening the sedation of the patient. Thus, while using the dexmedetomidine preferentially acts via normal sleep pathway, acting on the RAS system. So this gives us a light to moderate kind of sedation, which is beneficial for patients even while we undergo the weaning process.
Okay.
That's
so,
why I have chosen this.
Okay, okay. So now, are there any existing studies in this done? And how is your research different from those studies?
There has been many existing studies comparing dexmedetomidine and fentanyl, but mostly they have used as maintenance sedation as the primary outcome. While in my study, I have chosen the extubation time, the efficiency by which I can extubate the patient by choosing each of the drug has been focused on in my study as the primary outcome.
Okay. So what is your research method that you have opted? What is your research method?
Ours is an open study with a randomized control trial, and based on the number of patients in our ICU, we have chosen the sample size, which has been driven from the previous studies. It was taken as 60 with 30 in each group, and the first patient was allotted by a computer generalized randomized table, and thereafter every alternate patient was allotted in the alternate groups. And before initiating
So
the
one
sedation,
second, so
all
one second. Was it a blind study, or was it that you were aware which one is used for what?
ma'am, this was a blind study for the patient, but it was not a blind study for the primary investigator and the assessor.
Okay, fine. Okay. So what was the data that you were collecting? Like, you have selected the patient, you have put up this patient on this. So what was the data collection that you planned for?
Ma'am, my primary outcome was the ease of extubation. So my primary measure was the extubation time. This was determined as time when the sedation was stopped for extubation purpose up to the time patient was extubated out of the ventilator. This was my extubation time. And other secondary outcomes that include time on ventilation, time on sedation. I used a rescue analgesia because patients who were unable to maintain my target RAS score were given a rescue analgesia with fentanyl bolus. So how much boluses were needed? And I also had one secondary outcome about ICU delirium, about the onset of delirium while patient was given either of the drugs on ventilation.
Okay. So what were the most significant findings of your study?
I got two very significant results. One is dexmedetomidine group has significantly decreased time to extubate in comparison to the fentanyl, which was as significant as 0.001, highly significant. And second significant result, what I found that patients who were on dexmedetomidine based sedation, they had ICU psychosis lesser in number, as well as those incident of psychosis were more than fourth or fifth day on ventilation. In comparison to the fentanyl group, who had more incidence of ICU delirium, sorry, not psychosis, I repeat, ICU delirium, and they had the incidence of delirium on early to a second or third day on ventilation. These are the significant results that I got.
Okay. So your primary objective was on the ease of extubation and the hours
Yes,
of
ma'am.
extubation, right? And
Yes,
secondary
ma'am.
outcome was, one was to reduce the delirium. Second,
There was timing of duration of ventilation, duration of sedation,
yeah.
a rescue analgesia need, incidence of rescue analgesia need, and incidence of delirium.
Okay. 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 So, so when I don't know, Dr. Pandit is there. I can't see him. He wanted to do on the thesis. I can't
I'm
see.
there, but I actually did not hear her thesis when she discussed it, unfortunately. I had a phone call which came in at that time. So,
Okay, so she did it well actually. She has in short done a study on the ease of extubation with switching over from fentanyl to dexmedetomidine. So
Mhm.
she has tried to do the thesis. Sudeshna, you can just tell the results to sir. Her primary, you just tell your primary and secondary objective and your results.
One thing, Dr. Sudeshna,
Yes, sir.
I was hearing is that yours is a open label study. Okay, it's not a blinded study at all. So
Yes,
it's
sir.
no, there's nothing called as blinded for the patient. It
Yes,
is
sir.
always the
Always.
blinded for the researcher or not.
Yes, sir.
Patient is not informed of blinding because many of our patients, especially you are doing a sedation study, so it really doesn't matter how the patient can be informed at all. So it is the open label study, and I hear that you had randomized it, so which is good. First computer generated randomization followed by alternate randomization. So block randomization in a fashion we started with the computer randomization. Uh, What was your intervention group? Your intervention group was the group in which
Dexmedetomidine.
gave dexmedetomidine, right?
Yes, sir.
Yes. And the other group, the standard of care group, was your fentanyl group, right?
Fentanyl sedation.
Was
Yes,
there a standardized other sedative as well? For example, were you using midazolam or anything else along with either fentanyl or dexmed, or it was just purely fentanyl versus purely dexmed?
sir. It was based on fentanyl-based sedation versus dexmed-based sedation study.
So that was also
But
standardized.
Exactly, but sir, I had an also option that my target RAS score was to achieve -2 with the maximum doses of sedation. And if it was not achieved, I had given rescue sedation with fentanyl bolus doses. And that the total amount of bolus doses required was also calculated, and the number of times given was also been taken care of. But it was shown that there was no statistical significance between the requirement of the rescue sedation doses.
Sure. Just one more question for you, Dr. Sideshna. Did your patients have any standardized clinical diagnosis for which they were given sedation? For example, did you do it in a medical unit or a cardiac surgery unit or a mixed ICU? What kind of patients were they?
Yes, sir. I have in my demographics, I have already classified on the basis of the indication for the mechanical ventilation as well. And for the inclusion factor, I only included those patients in which the target sedation -2 is efficient as per their primary problem also. Like for patients who need muscle relaxant infusion, for lead who need deep sedation, the
That's not what I
neurosurgery.
asked. That's not what I asked.
They have been included as per the inclusion protocol.
What I asked is your patient group heterogeneous or is it homogeneous? So are you having, did you do it in just cardiac surgery patients or PAMI patients or medical patients, or did you do it on pneumonia patients only? What was the group of patients that you used? So it was, if it was a heterogeneous, that's fine. It's okay to have heterogeneous group, nothing wrong.
Yes, sir. I had heterogeneous group, but I left out those patients who required a deeper sedation.
So after randomization, you actually did not take them into account. Is that what you're saying?
No, sir. Before randomization only, I went through the patient data and I.
So you screened them, but you did not randomize them. You did not enroll them.
Yeah.
Sorry. Yeah. Okay. That's fine. That is absolutely fine. If you would have done that after randomization, then it would be a problem. Before randomization, that's fine. You have a pre-filled, pre-met criteria to enroll them.
Because if we see, sir, because with Dexmed, it was not very easier to have deepened sedation like RAS score -3 or -4, which is often required in neurosurgical cases. That was not possible with Dexmed alone. So I have already left those cases before even allocation.
Sure. Okay, I think it's a straightforward, simple. That's how the thesis should be for DNB. It should not be complicated. It should not be DM or DNB, whatever thesis you do. It's a thesis which is a requirement for the university exam or the board exam to be completed. Don't make it too complex. Don't try to have a very, well, it would be nice to have original research for all of you, but remember, you want your thesis to be accepted at first go so that it's out of your way and you can concentrate on the exam. And then if you're really a big researcher, you can continue to do research after that. But the examination point of view, keep it simple, keep it straightforward. Do not have complex researches going on, and write it in a simple way. Do not go into for complex statistical methods as well, because that is where you would get stuck with the thesis.
Yes. So good, Sudeshna, that was good. You had done it also very well. And thank you, Dr. Pandit.
Thank you.
That's very nice. Dr. Pandit, I think now the next thing, should we go ahead and do one of the literature review, the paper review?
Yes, please go ahead.
Because I think I did each section one with you. So that's why I thought I will do this also.
Please.
So we will do, next is the literature review. 1 minute. This, okay. So can you see the screen?
Yes, ma'am, I can see.
Yeah. So who is going to volunteer for this?
Ma'am, I was volunteering.
What's your name?
Dr. Gurkirat.
Oh, yeah. Oh, you're only the ones. Okay, fine. So have you read this paper?
Question on literature review of hydrocortisone. Yes, ma'am. I think I have read it. I'm not sure.
It was shared on the group today.
Oh, okay. No,
Is
I've
there
not read
anyone
it.
who has read it? Is there anyone who has read it? Otherwise, then there is no point in doing this, no, unless you have not read it. Anyone who can volunteer? Sudeshna, who is there who can volunteer in this?
Anyone interested, please?
This is also one of the most important aspect for the paper. If they've not read it, then how will they answer the questions?
Anyone here?
I believe nobody has read it, Dr. Darshana.
Okay, then what do I do? Because there is no point in discussing if they have not read it, no?
Completely agree.
Then I will just take them to Dr. Pandit. Then I shall do the quality part.
Please go ahead and do the quality part. Yes.
Because communication we have discussed quite a lot.
Yes.
I
Yes.
think
Good.
clinical audit and patient safety is one
Yes.
which we can do. Okay. Anybody who is volunteering for this? Who will volunteer, please?
Dr. Vishnuraj? Dr. Vishnuraj? Anybody interested?
Such a big,
I can
somebody
try.
has volunteer.
Gurkirat is agreed.
So first question is, how does department measure compliance with clinical protocols, and what actions are taken when they single clinical?
Ma'am, protocol compliance,
Yes.
quality.
So any
Mention one
protocol that you are following in your
protocol that your
one.
entity is following, and then we will add them. For example,
Yes.
a ventilator associated pneumonia, VAP bundle protocol, right?
Yes,
Or
ma'am.
your CRBSI protocol.
Ma'am,
Maybe
Yes, is their next questions. I think go for WAP or whatever
yes, ma'am.
protocol
We
you
are
are
following
comfortable.
a CRBSI bundle. We are
now
following
go for
VAP.
the VAP CRBSI. As she is telling, there is a
VAP
question number
bundle.
3.
Yes, yes. Following VAP bundle, and we are and actions taken from deviation.
No, so
Ma'am,
first and
compliance to
foremost,
protocol is recorded.
yeah,
Percentage of compliance to protocol is recorded.
if you have to measure the compliance to this WAP protocol, okay,
Yes.
how will you measure it? How will you see it that people are following it on whatever are the set protocol, requirements?
Number of patients that are ventilated. We are calculating number of patients that are ventilated, and on the number of errors we are calculating, and minusing that from total number of patients that are ventilated, and the percentage we are then calculating.
Okay.
Like suppose VAP, if the like if the components of VAP bundle are not getting followed on the bedside, we've got a auditor who takes a everyday makes a list of patients who are on ventilator. Their data is collected. Then there are VAP checkpoints or VAP bundle checkpoints are made, and that simple tick mark and cross are made on that VAP checkpoint, or name is written. And whatever checkpoints are not being fulfilled, they are they are then ticked. The number is calculated at the end of the month. Total number of patients ventilated, total number of patients where compliance to VAP bundle protocol was followed, and then the percentage is taken for the quality purpose. And that is cross-referenced by the number of patients, like incidence of pneumonia per 1,000 patients ventilated. Yeah.
Okay, and what are the actions that can be taken in such patients when there are a deviation? What are the ways that you will try to improve the compliance?
Ma'am, educating the
Very good,
staff
yes.
qualification,
Hmm.
understanding the reason why the WAP protocol is not getting followed, whether that is because of modifiable factor, like that can be modified at our end, or they are non-modifiable factor which are not in the hands of our ICU practice. And then we are calculating how much compliances we are getting, allowing it, how much compliance of protocol we are allowing, and how much we are letting it go to follow the indicator.
Okay. When we summarize, we'll put you points forward to what is more details. Second question, what strategies are in place to reduce medication errors? And how is their effectiveness monitored in the ICU? See, we know ICU is the place where maximum patients receive. The orders keep on changing, no? So there are a lot of errors which can happen. So what do
Yes,
you think are the strategies that need to be put in place to reduce them?
digitalization of order
Hmm.
we have is one of the method. Number two, again, ma'am, the effectiveness is monitored that the incidence is reported. The incidence data is calculated. Number of incidents of medication error are calculated per 1,000 patients. And strategies, then we are comparing it to the latter part when we are looking at what strategies we used then, like for reducing, and whether those strategies are improving or not, like whether after digitalization the quality has improved or not, or after not after like using paper and pen method to documentation, whether in 1 month we have used paper and pen, another month we have tried to focus on digitalization where the error rate was less, so that
Okay, so what are the type of medication errors that you know about? Because for that you will have to know what are the types of medication errors, right?
uh, medication errors.
Have you filled anytime any medication error form?
Yes, ma'am, we have filled medication error form.
Hmm. So what are the
Uh,
type of errors?
uh, Ma'am, clerical error,
Hmm.
written
That's a prescription error, right? Yeah.
prescription error, prescription
Hmm.
error.
What do you see in that prescription if it is written, if it's error out? When do you call it as a? Because I'm just trying to make you understand what is that prescription error which is there. When will you say the prescription is not right?
Ma'am, perception error is there, whether that what we have written is perceived differently. Prescription error is there, then what the writing error is there, or the delivery error is there, whether that medication delivered was wrong, or induction error is there, whether the induction when that indentation error is there.
Hmm.
I'm not sure about that, but I've filled a form, so I know an idea.
Okay. Okay, fine. Okay, chalo. How does your department ensure adherence to infection control practices such as hand hygiene and CLAPSy prevention?
Ma'am, hand hygiene, number of times the hand washing has been done is filled
Hmm.
per day, per 24 hours.
Hmm.
Uh, total number of staff is calculated, and the based on that and multiplication with 30, the per month data is calculated, and the number of times the compliance to hand hygiene protocol has not been followed, that percentage is taken. And and based on that, the hand hygiene compliance is followed. Send CLAPSy prevention bundle just like that, whether the proper indentation has been done of chlorhexidine or not, whether there is entry of the indentation is there. Number one. Number two, how many times the de-lining of procedure has been done, and the dates have been marked, and the reason why the de-lining was not done was documented. We have like the patient name is the patient's name is filled, the day of central line insertion, date of removal is written, and then the bloodstream, and if number of cultures we are sending and number of cultures that we are turning out positive, we are calculated.
Okay.
Yes.
Okay. What key performance indicators are used to assess patient safety and quality of care in ICU?
Ma'am, fall rate, patient fall
Yes.
rate.
Very
We are
good.
calculating needle stick injury rate.
Yes.
Uh,
But needle stick is for employee, right? Patient
sorry,
safety.
ma'am, not for needle stick injury. Patient fall rate. Risk adjusted mortality rate has been calculated. Ma'am, medication error rate, like on number.
Yes.
Reintubation rate.
Yes.
Number of readmission to ICU.
Okay, fine. Last one. How is the patient and family feedback integrated into the quality improvement initiative? How can we integrate that?
Ma'am, written family feedbacks can be interpreted into yes or no, like column, whether the positive feedback was there or not, and then total feedbacks can again be calculated, divided by the negative by versus positive.
Okay.
Feedbacks. Denominator can be taken as total number of feedbacks calculated.
Okay. I think Arindam, shall I start with the explanations, feedback?
Yes.
Yeah. I don't know if Dr. Pandit is there, but I right. So clinical care department measuring the compliance. So you were very right when you said that first check on the WAP bundle compliance which is there, and there is a set of the things that they need to do. So if there are 7 components, whether all the 7 components they were compliant with or no for all the patients who are on the ventilator. So there are 2 ways that can be done. Either it can be done randomly on some days, or it can be done seen to it that each and every day it is collected for the ventilated patients. And if there is a deviation, the most important part is that the people should know on which are the deviations where we are missing. That is what they need to know. So there are 2 things. One is appreciation, and one is also letting people know where they are going wrong, because then only will there be an improvement. So if they are doing a very good hand hygiene, but they are not actually doing a proper suctioning, then this needs to be actually informed to them that this was done very well, but this is somewhere where we need to improve. So encourage is something which is very important that we need to do. Second is are in place to reduce medication errors, and how is their effectiveness monitored in the ICU? all of you need to understand that medications in ICU is very important, especially we have patients with in ICU who have got high risk medications like heparin, then adrenaline, vasopressor support, lot of these things that we have our patients going through, you know. So to reduce the medication errors, what are the strategies that need to be employed? Very important. First and foremost, it starts with the prescription practices, right? So we as doctors have to write a prescription properly. If you are writing in paper and pen, then you have to write in capital letters. You need to understand that you write the numbers properly. Avoid verbal orders for high risk medications. See to it that you have written it properly. If you give verbal, then there has to be a communication which is proper, and there has to be a repetition of the verbal orders as far as possible. Then for the labeling of the medications, the infusions that are made, a proper counter check by two people. Narcotics, there are two people who need to check before it is administered, and also at the time of the disposal. So these are a lot of strategies. I think even if you go to your hospital, most of the hospitals are NABH accredited or a
Dr.
JCI
Darshana,
accredited.
sorry to
Sorry,
interrupt
sir.
you. Can I leave? Can I take your
Yes,
permission?
sir. Yes, sir. What?
Then
Yes, sir.
can I
Yes, sir.
leave? Thank you.
Yes, sir. Yes, yes.
Now, what on popular demand, I got a lot of requests from it. We would formally announce, but I'm just informing all of you that we will have certain classes on medical statistics, right? It is all included for every one of you, whosoever has come forward or others. One on the quality accreditation, patient safety audit and others. And also I've requested Dr. Pandit to give a good overview on communications and ethical decisions and end of life care. So couple of all these things we will club together and we'll take a session. I've already spoken to certain people who will take this say. I think these are the areas that we really need to brush up before the exams. So it would be useful for you. So we'll give you the information regarding this. Just allow us some time. Darshana, please continue.
Thank
Pandit
you.
sir, you can
Yes.
take a leave.
Yes,
Thank
sir.
you very
Thank
much.
you,
Thank
sir.
you, everyone.
Thank you.
Bye-bye. Thank you.
Thanks. Bye.
Thank
Bye.
you,
Bye.
sir.
Bye.
Thank you.
So I was on the medication. So as I was telling you all that, you know, these are certain things like the high risk medications, the narcotics that are being used in the ICU. So there have to be a set protocols to use it. And there has to be where it is monitored also. Then comes some effectiveness monitoring, very simple way. There is one more thing is it's not only about the medication error, it's also going and checking on the practices. So the types of medication errors which have to be captured are lots. It is prescription error, omission error, administration error, dispensing error, you know, then the compliance which the patient does not follow. So multiple errors are there. So you need to know about it. Please read about it if you have not read it about it. Then comes, what does your department, how does your department ensure adherence to infection control practices such as hand hygiene and CLAPSI associated prevention? So here you need to say that the hand hygiene to be implemented first and foremost at the time of the induction itself. There is a proper induction which includes on what are the hand hygiene practices that we need to follow, for as well as for the clinicians what are the CLAPSI prevention bundles that we have. Hand hygiene, very important, is on training. Training includes two parts. One is on not only on the steps but also on the movements of the hand hygiene. So how do you check on the adherence to infection control practices? You said it very well that you need to also check on what are the things which are available to ensure that the hand rubs are available at the bedside, the basins are available at the bedside, to ensure that the compliance is followed, to people not wearing gadgets in their hands like rings, watches and everything, to see to it that compliance is followed, that during procedures it is removed. Fourth is, as I told you, the steps are followed at every point. And very fifth, the most important, is on all the five movements that are being followed. Most commonly, we all know that after touching the patient and after touching the patient surrounding, it is not followed. So this is something which we need to do. For central line associated CLAPSI prevention, very simple. You need to just say that you need to ensure that the bundle is followed. The bundle has components of before insertion and after insertion. So before insertion is the insertion bundle, and secondly is the maintenance bundle. So insertion bundle starts from selection of the site, where femoral site has to be avoided. As far as possible, use the subclavian or the jugular, and then all the steps that are followed from washing your hand, capping, blowing your hand properly, consent being taken, ensuring that the parameters like the platelets and PT-INR have been checked, as well as draping the patient, and then going ahead with the procedure and doing it as a sono guided procedure. And then comes the maintenance bundle, wherein it is all about, and also the number of pricks that were taken. And then comes the sono guided procedure, and then the prevention has a lot of aspects on how the line is being used, what is rub the hub, how many times the line is how many times the dressing is done, is the dressing soiled. So all those components which are there have to be told in detail. Fourth question, what key performance indicators are used to assess patient safety? You were very right on the number of falls, on the number of medication errors that happen, on the number of this thing you said about readmissions and readmissions and reintubations. So see, in quality, when it is coming to KPI, it is divided into outcome measures, safety measures. Okay, and quality and outcome come together. So as you said, it is very important on the mortality rate. It is very important on the readmission rate, which is within 48 hours, reintubation within 48 hours. Then it comes to also the number of pneumothorax that occurred after a central line insertion, that is the number of complications, the pressure ulcer rate, the number of patients who develop pressure ulcer, and then safety, as you said, medication, as well as on the fall rate. Okay, and also on the injuries related to restraint is one of the things which is related to patient safety. Then comes, how is patient and family feedback integrated into quality improvement initiatives in the ICU? This is very easy. The feedback forms always have a component where it mentions that what are the measures which need to be improved in the ICU. And I'm sure most of your hospitals have one of the most commonest feedback, and which is to reduce the noise levels in the ICU. Right? So it is one of the examples that you can give to your examiner, that the most commonest issue which happens in the ICU is the noise levels which are to be controlled, and that is something which needs to be looked into for a quality improvement. Then there may be many things. It may be about the timing of the food. It may be related to the communication. It may be to the related to the not understanding what the doctors have said, and they need an improvement in that. It may be that some patients may complain that, I was not explained the procedure in detail before going ahead for the procedure. So these are the way the feedback can be integrated. So this is some things which I had in mind. Arindam, anything, Paras, anything you want to add? Paras, are you there?
You have covered everything. Yeah, most of the things.
Arindam,
Yeah.
anything?
Nah. Anyway, we will decided that we'll have a very quick class on remaining parts. So I think you go forward with your Viva.
So now the first part of everything I have done, the first set of questions. Do we have to go for the second set? Nobody has read the paper. Literature review nahi hua hai because no one has read the papers.
So
sad.
let's do one thing. Let's do 2 more rounds of, I think you can finish quality and communications itself. Paper will take on the next day.
Okay.
So we are requesting any one of you can specify the name. You read the paper so that we can come back and take the paper tomorrow itself. So any volunteers for the paper? We will review the study paper. The study paper already given, Sudeshna?
Yes, sir.
Okay, so one is Urvi. Urvi has come forward. Urvi will then. Anyone else? Anyone more volunteer for the study paper?
Bhavna is there. Bhavna has volunteered.
Okay, so Bhavna and Urvi, right? And Bhavna, Urvi. So you guys can decide amongst yourself which one you want to, right? Do not read it right now. Read it only for an hour before, right? Or so that you can simulate the exact the exam scenario itself. So if you read it now and then all through you take all informations and others, it won't simulate the exams. In exams, you will get 1 hour before or maybe a couple of hours before. And you won't get chance to open up internet and look into another stuff itself. Only the paper and your knowledge, residual knowledge. So be honest with it so that uh, you know where you do stand and what else has to be done. Okay, Darshana, over to you.
So the second set of question, it was for the same patient, but is there any volunteer? I need volunteer.
Can you type your name in the chat box?
So which one you are starting?
No, so what I'm trying to say is, I think this one of the communication Dr. Pandit has done in depth. Do you want to still do it
Nah, then you can skip.
and
You,
do the quality part?
I think quality you do.
But
Guys,
then
come forward for the quality. This is one of the area we all are reasonably sure that you guys will struggle to. So come forward, take the exams.
do quality, and then I think the papers anyway we are doing tomorrow. So anyone for
We
quality?
can do the thesis one more and then we can finish.
Yeah.
Quality, come on, Sudeshna. Otherwise, you take random allocation.
Dr. Urvi has volunteered.
Okay, volunteered. Chalo.
Again,
Urvi, come
Urvi,
on. Good.
okay.
Okay, I'm putting up the questions to Urvi. Good. So, what are the key steps in conducting a clinical audit in the ICU? And how do you ensure a continuous quality improvement? Urvi, go ahead.
Yes, ma'am. So the key steps of conducting a clinical audit in ICU and to ensure continuous quality improvement. So the key steps in conducting a quality audit, clinical audit will be to observe the procedures, whether the ventilator associated pneumonia protocols or the VAC bundles, or whether the CLAPSI bundles are being followed in the ICU. Whether we have to ensure whether there is an appointment of infectious disease protocol nursing staff, as well as an uh, infectious disease committee who is handling over the continuous improvement of the ongoing nosocomial infection in the ICU, and to curb the measure for the isolations, and to maintain the uh, 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 negative and positive pressure areas, as well as ensuring the uh, HVAC systems in the ICUs.
Okay.
And also doing the drug audit and seeing whether any kind of adverse event like fall or the bed sore rates in the ICUs.
Okay. So fine. When I wrap it up, I will answer to you on this, how to go about. Second question: what is a sentinel event, and can you provide examples of sentinel events that can occur in the ICU, and what are their potential causes?
Mm, I think, ma'am, sentinel events are the unanticipated or uneventful events which have occurred in our ICU. So, probable can be an underdosing or overdosing of drug, or any kind of mishandling of the ET tubes or the IV access or CVP lines or the arterial lines. When we are proning the patients, then there is uh, dislodgement of the line, or uh, if proper suctioning are not done, then there can be uh, endotracheal tube blockage or any kind of hypoglycemic or hypothermic event which are not being uh, addressed.
Okay. Okay, fine. What measures can be taken to improve communication among healthcare providers in the ICU to reduce errors and enhance patient safety?
Measures to improve communication among the healthcare providers. And there should be a proper communication between the doctors and the nursing staff.
Yes.
We should either give verbal orders and repeat it, or we should give written medicine orders to the nursing staff. Uh, some procedures need to be explained to the nursing staff, how and when to be performed. There should be a proper handover among the both doctors and nursing staff whenever there is any shift in the there are duty shifts in the ICUs, and if some interventional procedures which are not being commonly done in the ICUs, then proper board of instruction should be hung near the bedside of how to tackle the issues, and the nursing staff should have proper communication with the registrars or the doctor on duty regarding the ongoing events or troubleshootings or any kind of uh, alarms being noticed in the monitors or the ventilators or the interventional instruments if being used. And there should be a healthy conversation and no any kind of communication to hold a person wrong or they should be done. They should be encouraged to uh, correct the mistakes, and uh, they shouldn't be threatened for the same, for a
Okay.
healthy communication.
Okay. Now you can just tell me how will you track and benchmark the KPI for mortality, VAE, and readmission in ICU?
As the ICU track and benchmark key performance indicators such as events, mortality, and readmission rate.
You have
For
heard
the
of the
ICU, yes,
first you tell me of mortality first, you say. What is the formula and how do you do it?
uh,
This is the most commonest question you all
yes,
are asked.
yes.
Hmm.
For the mortality in the ICU, we can maintain a uh, register in the ICU, and we can have the mortality uh,
Something
um,
which was said risk adjusted mortality, or you
yes.
can say standardized mortality ratio. How will you
Uh,
calculate that?
yes, the standard SMR ratio can be calculated like how much mortality occurred in the ICU upon the predicted mortality events into 100.
Very good. Yeah. So how do
Um,
you find out the predicted mortality?
uh, if we are seeing for the predicted mortality on the basis of the severity uh, of the patient of severity of illness of the patients who are admitted in our hospital.
Okay. Hmm. But how do you bring out that figure, predicted
Uh,
mortality?
predicted mortality can be breakdown out based on the severity score, like the SOPA score or the uh, Apache score. Not exact, I don't know exactly.
Okay. Yes. 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 Very good. Okay. And readmission rate?
Readmission rate is based on how in 24 hours if any patient is going out of ICU and returning back from the ward,
Hmm.
or
Within how
within
much time?
24 hour within 24 hours, within 24 to 48 hours if the
So what is
uh,
the formula?
I think it is readmission is ICU upon 24 hours upon total number of patient admitted into 100 probably. Actually, exact I don't remember, ma'am.
Okay. What is VAE? You know what is VAE?
Yes, ma'am. Ventilator associated events. They are from the ventilator associated infections. There is a change in the baseline FiO2 or the or the increase in the WBC count after a baseline stable period of at least 48 hours of decrease in the ventilator uh,
Hmm.
of decrease in the ventilator um, settings.
Okay.
So do we have to describe all the things the
So
ventilator
I'm
associated
asking you
infection?
because this is no, so I'm asking you because this is a practice session. Acha, now you tell me, suppose if you have to benchmark this, how will you benchmark? Do you know what is benchmarking?
Benchmarking means uh, uh,
This is something,
idealization of a
okay. Okay, chalo. Next, what role do
means
evidence-based?
benchmark means how comparison of our ICU with a standard ICU
Yes, what is the
is,
standard?
and we have
Yeah,
to follow that throughout and see whether we are up to the mark with the bench.
fine. I'll come to that. I'll come to that.
Yes.
What role do evidence-based guideline play in maintaining how high quality care in the ICU?
How do evidence-based guidelines play in the high quality care in the ICU?
So in critical care, we
Ma'am,
have some
yes,
evidence-based
yes.
guidelines. What are they? Any one example you take it, please.
Um, Evidence-based, we can say, for example, Proceva trial, which was done for proning, can
Hmm.
it be given?
Okay.
Or uh, the evidence-based guidelines like um, the CRT after Andromeda trial in the latest sepsis guidelines.
Hmm.
Or another example can be the evidence-based guidelines actually help to be updated regarding the recent evidences. For example, uh, there are evidence that balance cell solution against normal saline they decrease the AKI incidence for uh, if we want to go in the resuscitation. And even the evidence-based guidelines helps to be at par with the current treatment which is going on globally.
Okay. Okay.
So uh, we can change our strategies on how we tackle the issues or like evidence base if we are managing the sepsisemia or sepsis with the uh, SSC guidelines, surviving sepsis guidelines, which we are going on, maintaining the 1 hour bundle. We
Yeah.
have to diagnose the sepsis and septic shock within 3 hours, and we have to give the antibiotics within 1 hour of
Okay.
diagnosing the fluid strategies and
Fine.
what kind of fluid can be given,
Fine. So you
or
had
what should
it
be
in
the
there. Okay. Okay.
ventilator
Chalo.
strategies.
Okay. So just to brief you all now. Okay. So you started it well. What are the key steps in conducting a clinical audit in ICU? And how do you ensure quality improvement? See, ICU is a place where there are a lot of things which we do, and there are certain ways that we do it. But whether everyone is doing in the same manner is which is the most important part. Okay. So you need to understand which is your problem area. When I'm saying about a problem area, it may be simply that you have a place where you're having an increased incidence of CLABSI or increased incidence of COTI, or you are having an increased incident of a medication error or any of those things. So you first find out what is the problem area. Secondly, then you choose what is the audit that you're going to do. So if I have to tell you about the audit that you need to do, simple, just you take it for uh, um, Simple, I'm giving you a clinical audit on what are the practices which are being followed for high risk medication. We all know high risk medication, so you just take in high risk medication, a type of medication. So it is, suppose if you take the vasopressors that are given to the patient, like either adrenaline, noradrenaline, or a vasopressin. So which are the drugs which will be included in that, right? So if you see that the number of medication errors were high and those were related to the high risk medications, so you will select which are the medications, you will select which is the ICU you are going to audit, you will select what is the number of samples that you will audit, that is whether you are going to do it daily, whether you are doing 20 patients a day, or whether you are doing for how many days. If it is 20 patients per day, then how many days, okay? Or a total. So you come to a sample size and then you divide it into the number of days. You put up who are the team who are going to do the audit. You put up the audit parameters that you are going to audit, which is the unit, which is the patient, which is the drugs which were there, and what are the kinds of errors. Was it a labeling error? Was it a syringe pump alarm which was happening and which was not attended? Was it that the infusion got over and there was no backup which was put up and the patient did not receive and there was a catastrophe related to that? So these are the certain things that you need to put up, and then you do the analysis of the data. Okay, and then once you do the analysis of the data, you come with the observations, you go and tell to the team, these are the things which we have done, this is what where we need to improve, and then you start training the people on those and prospective. Retrospective is they go and collect data for a questions on clinical audit. Anyone? Yes, take a particular area, because if you are going to tell multiple things together, it will be a hodgepodge over there. So like I told you, if I'm talking medication, I can just take a medication error, or I can say a simple hand hygiene, or I can say just a WAP, or I can just say on documentation
Okay,
audit.
ma'am. Thank you.
Okay, so that is few
Yes.
things that you need to do. Second question is sentinel event. You very well defined it, that it is a your definition that is most important. As you told, it was very perfect. And examples of sentinel events in ICU are a lot. Very important medication errors, okay, where it can be leading to a death also. It can lead to, we may not even realize, but there are multiple times I have seen medication errors where there are antiarrhythmics or same name drugs which are given in a wrong manner. Okay, then comes our example is wrong blood transfusion, which can occur even though it is ICU for a massive blood transfusion or any kind of a thing. So wrong blood transfusion can be another one of the sentinel event. Wrong medication administration can be another one of the sentinel event. Okay, then there can be also something where there is a disconnection of the equipment, maybe like a syringe pump which was put on charge, or it can be disconnection of the ventilator where it has led to a patient's life, or it can be also on the wrong side of the procedure, which is also some, we do lot of procedures in ICU. At a time it may be that it's a very busy day and you may have to do a procedure over there, so two three procedures same time you may have to do. So that those are the incidences which need to be taken into consideration. Okay, then comes what measures to taken to improve communication. You said it very well. Handover is one of the most important part of communication, and continuity of information to the patient. So you know what you need to do, you divide the handover into two parts. One is within the department and other is outside the department. So within the department, it is by continuing the handover between the shifts. So between the shifts, it's again between the nurses and between the doctors. Okay, and then during the rounds, it's with the team. So between the shifts is the handover which is happening. Secondly, it is during the rounds that the handover happens and a care plan is made, which is done with the entire multidisciplinary round. And then comes the handover between departments. So when you receive a patient from the operation theater or from the emergency room or from the court team or from the cath lab. So these are all the handovers which are very important when the patients are critical coming to the ICU. Okay. Then how does the ICU track and benchmark key performance indicators, which I asked you for VAE mortality and readmission? You were very right when you said about the mortality rate, which is SMR, which is by dividing into the observed mortalities divided by the predicted mortality. Predicted mortality, you see to it, if you have got 300 patients in the ICU, 300 patients Apache score you calculate, and then you bring out an average of that. Okay, so you bring out an average of that, and then that is the average score. So out of 300, if you were expecting a 17%, is your average score which comes of the Apache, then that is what is your expected mortality. Okay, and if you have your mortality in the hospital which is around 12, so it will be 12 divided by 17 and you will get the figure. Okay, and if it is less than 1, then it is good. If it is more than 1, then you need to look into it, why the mortalities are happening. And wherein actually in our hospital we also do one more way which I pick up, is that if the Apache score is less than 15, then we go and see which were the areas where we could improve or what went wrong in that patient where we could do something and we missed somewhere. Okay, so that is about the SMR. Readmission and benchmarking is set by the IDCCM as well as the SCCCM. So this is the benchmarking which is derived from them, and that is what is the benchmarking, because it helps us look at our performance. Readmission is actually the number of readmissions which occurred within 48 hours after transfer out of the ICU. Okay, so total number of patients who had come back to the ICU within 48 hours of transfer divided by the total number of discharges from the ICU. Discharges, transfers from the ICU. Okay, so that is what we will divide, and into 100, that will give you the percentage. Okay, so actually ISCCM has set up the percentage as 6%. Okay, so if it is less than 6%, you're doing well. If it is more than 6%, then you need to see for each case why the patient had come to the COPD exacerbation. Same. So then to be shifted at the time of shifting is what we need to see. Okay, VA is something which is new, which one of new, and which also looking into the ventilator associated complications, which are like our gaps, effusions, pulmonary edema, all of them are taken into consideration. Okay, what role do evidence-based guidelines maintaining high quality in the ICU, and how are they to be implemented in daily practice? You did it very well over there. So you need to just put up, yes, there are multiple evidence-based guidelines. I would take an example of 1 hour bundle of sepsis. And in the 1 hour bundle of sepsis, it's about looking at the QSOFA, and first is the suspicion of the sepsis. Second is sending all the blood investigations. Third is about so in that blood investigation, it includes the blood cultures and the cultures which are relevant for that particular case, which need to be sent, the fluid resuscitation and antibiotic administration within 1 hour. So this has to be tracked, and we need to understand on the performance of that evidence base. Implement is by training the staff on this, putting up as a quality improvement project, train the staff, collect the data, and see to it where the non-compliance is and what are the reasons for the non-compliance. Did you get it, Urvi?
Yes, ma'am, I got it. Thank you so much, ma'am. Yeah,
Okay.
will improvise.
Have you understood? So yeah, so this is how we
Yes,
will
Miss.
answer. Okay, I think now we will just do one more thesis and then I think we can wrap up. So who is presenting the second thesis? The questions remain the same. Anybody for thesis presentation?
Please write your name in the chat box. Anybody who's interested. Anyone? Dr. Urvi, would you like to go for it? Dr. Arnav is interested.
Arnab.
Yes.
Okay, Arnab, we'll do your questions. So the Arnab, just tell us in short, in just in 5 to 7 minutes on your thesis. Don't tell everything. You just tell me your title of the thesis and what you have done. Just that much. Then we'll ask you all the questions in the thesis questions that we have. Arnab, we
Okay,
can't
ma'am.
hear you. Yeah, just tell me what is your thesis.
Uh, Ma'am, my thesis is a correlation of platelet lymphocyte ratio with Apache-2 score in patient with sepsis and septic shock admitted to medical ICU, a prospective and observational study.
Okay, fine. Very good. So now let us do on the questions. Okay. So I'll ask you the question. So what inspired you to choose this topic and what problem does it address?
Ma'am, as we all know that Apache-2 is a well-validated score to predict the mortality, but there are two things about Apache is that we have to calculate it beyond 24 hours, number one. And number two, there are multiple parameters in Apache which we needs to calculate to get the result. So in recent times, I have seen some studies going on, not very good in numbers, but few studies who have studies on different scores like platelet and absolute lymphocyte score and platelet or neutrophil ratio to see their predictability to predict the mortality in patients. So I choose this because platelet and lymphocyte, this PLR ratio, because this is a very simple thing. We can calculate.
Arnab, your voice is gone. Arnab, we can't hear you. Arnab? Arnab, we can't hear you. Arnab, are you there?
And he's there, but
He's put on mute.
yes,
He's
I'm
on
trying
mute.
to unmute him, but unfortunately.
Arnab, you're on mute.
Ma'am, actually, can you hear me?
Yeah, now we can hear you. Tell us. Yeah.
Ma'am, actually, I don't know. It got locked out somehow. I don't know why.
Anyways,
How?
okay. So
Yeah.
anyways, the
Yeah.
second question for you is how does your research build on or differ from the existing studies in this field? Hello, any existing studies on this?
Yes, ma'am. There are some studies, not very much studies, but there are some studies which have been done from the Chinese population on these things. So no good studies has been done in India on these things. So I wanted to see the validity of platelet lymphocyte ratio, how well it is correlating with the Apache-2 score in Indian population.
Indian population. Okay. Can you justify your methods and explain why they were suitable? What method have you used for your research?
Ma'am, it is a observational study and it is a single-centered observational study and
It is a
um,
prospective or retrospective?
Yes, ma'am. It is a prospective study, prospective observational study.
Okay, fine. How did you come on the numbers? How did you decide on how much was your sample size?
Ma'am, the sample size was 100, and it was taken from a previous study based on as a baseline study, and it was calculated from the formula from the previous baselines, based on a previous baseline study.
Okay. So how did you collect your data? What are the
Ma'am, the data
parameters?
was yes, ma'am. The data was calculated from the patients coming to medical ICU, and I have calculated their from the CBC. I have taken the platelet count and absolute lymphocyte count, and I have made a ratio of the PLR. And along with that, all the parameters which are included in Apache 2, I have taken all the parameters, and I have seen how well PLR is correlating with the Apache.
Okay. So how was the data analyzed? Means any particular statistical analysis was done?
Yes, ma'am. The correlation was seen by Pearson correlation by correlation, and it was seen linear correlation with uh, index of point 8, which was
Okay.
positively correlated, and mm, and ma'am, and the sensitivity and specificity was calculated from the area under the curve of ROC curve.
Very good. So what are the most significant findings of your study?
Ma'am, as I have seen that PLR was correlating well with the Apache 2 with a correlation index of 0.8, uh, showing a positive correlation, and the sensitivity and specificity was 80%, 83 and 85% from the area under the curve.
Okay. Okay, good. You have answered it very well because you have done your thesis. You have understood it. So this is how you need to answer. Actually speaking, you need to know what method you have chosen. How did you derive the sample size? Somebody may ask you also which was the paper from which you derived your sample size also. So this was very nicely, crisply answered. Actually, Arnab, you answered it crisply to the point. So really good way of presenting your thesis and being on time for it. Paras, anything you want to add over here for him?
No, I think he presented well. What was your like? Did you take consecutive 100 patients? You excluded any patients like immunosuppressed patients, or
Yes,
what
yes, yes, sir.
inclusion
Yes, sir.
exclusion criteria?
Yes, sir. Based on my exclusion criteria, all the patients who were patients on steroids or patients of carcinoma or patients on any tropical illness in which I am suspecting a low platelet and lymphocyte ratio, these patients were excluded. So only the patients whom I was suspecting in a patient of sepsis and septic shock, those patients were included.
Good.
That's good.
Good. I think he answered it very well. He was very crisp in his
Yeah.
answers. That's the way it has to be done. So this is a message for everyone. The more crisply you answer and the more confident you are, the Viva will finish on time, and you will be able to answer all the questions which are put forward to you. And that is your way, because then your confidence increases and you don't, just stumble around anywhere. So this is what is my message to everyone. Arindam, I think we have done with all of this, and for paper, they will have
So
to just.
we'll do the two long cases and two short cases tomorrow, along with the papers itself. I think we have to add a class for the the Vivas itself, because Vivas have been little late, and I think people are in. We will discuss amongst ourselves and let you know. Let us meet tomorrow at 6. Complete the long case, short case, and in between, Darshana, I invite you to complete the review of the paper itself. We will be still be remaining with the one set of the tables itself. We'll complete it at, as well as discussed before, we will come up with a class where we will try to cover medical statistics or how to analyze a paper and then the quality, little bit of accreditation, audit, basics of communications, ethics, a little bit of medical legality, particularly on end-of-life care issues and withdrawal of life support, because these are frequently asked questions in that way, and we thought that we need to. Just let us know in the group that you want these classes. Do you want this class? We will consolidate it into one class, longer class. You don't have much time to ponder upon. So write it in the group that you are enrolled, and so that we do know that majority of you need this class to be, and then we will organize it. So thank you. Good night, all of
Thank
you.
you.
We will
Night.
meet sharp at 6, and tomorrow would be 2 long cases, 2 short cases, and the 2 papers that need to be analyzed. Kindly write to us that whether you need the class. Thank you.
Thank you.
Good night.
Bye-bye. Bye. Bye. See you.
Thank you, ma'am.
Thanks,
Thank you,
Paras.
sir.
Thank you.
Thank you,
Thank you,
Paras
everybody,
Bhai
for
and
joining.
Darshana ji.
Yes, yes. Thanks. Bye. Bye. Thanks.
Thank
Bye.
you, Paras, sir.
Thanks. Bye.
Thank you. Good night, everyone.